Good morning and welcome to the Healthcare Affordability Board meeting. We are going to convene as a subcommittee and we will convene as a full committee once we have a quorum present. We'll begin with the executive updates.
Good morning, everyone. Elizabeth Landsberg. I'm going to start with just going over the agenda. So if we could pull up the agenda slide, we're going to have executive updates from Vishal Pagani. And then after the minutes, once we have a quorum, we will start with agenda item 5A, an update on hospital outpatient spending measurement. So we've been working with many in the industry and other healthcare entities to figure out how to measure hospital outpatient spending, and look forward to the discussion and our current thinking about potential methodologies there. Then we'll go on to item 5B, follow up on hospital sector target methodology and values, including a summary of public comments. So we received more than 300 comments about the possibility of a hospital sector target on high-cost hospitals. So the team has done summarizing of that important public comment. And then we will move to the action item for the vote to establish a hospital sector target. So I had a chance to chat with a few of you before the meeting started. Just to be clear, we will take public comment after every substantive item, and we will certainly take public comment before there's any votes after a motion is taken. If the board does not vote on a hospital sector today, the action item will be placed on the May agenda. After the items on hospital spending, we will move to an update on our CMIR program, Cost and Market Impact Review program, and time permitting on equity and quality measures, and our behavioral health definition and benchmark. So I'm going to be skipping my executive updates. We have so much to cover today, but I would like to remind board and staff and speakers to please speak into your microphones to make sure you can be heard in the room and online. We have a lot of online participants. And with that, I will turn it over to Deputy Director Vishal Pagani.
Thank you, Director Land. Thank you, Director Landsberg. I first want to mention that on April 17th, the Office of Administrative Law approved amendments to the Total Healthcare Expenditures Data Collection Regulations with an immediate effective date. I'd like to thank the board, the advisory committee, members of the public for their thoughtful comments, and to OCA staff for their successful development of this rulemaking package. Next, I'd note that the Office of Administrative Law, or OAL, has approved the regulation defining hospitals as a sector. The regulation became effective yesterday, April 21st. The approved regulatory documents are available on OCA's section of the Laws and Regulations webpage on the HCI website. So I'll take us to the next slide. I want to note that OCA has posted on its website documentation that includes programming code and step-by-step instructions for users to use publicly available HCI data to calculate the unit and relative price measures of commercial inpatient net patient revenue per case mix adjusted discharge and commercial to Medicare payment to cost ratio. OCA has also posted a data set with unit and relative price measures for comparable hospitals, which was the basis for OCA to identify high-cost hospitals. Next slide. So through OCA's continued engagement with the public and stakeholders, we've realized there's a continuing need to educate and share information about what the spending target is and what it is not. So the spending target, I'll start with the left-hand column regarding what the spending target is. The spending target tracks and evaluates the growth of healthcare spending. It is a measure of per capita growth when reported statewide total healthcare expenditures is the annual sum of all healthcare expenditures on behalf of residents for healthcare services covered by public and private insurance. The intent is to slow healthcare spending growth so that it does not continue to crowd out household budgets for other necessities such as housing, food, and education. The spending target is a long-term framework for industry action. Healthcare entities have the flexibility to manage growth in prices, volume, or both, meaning they are challenged to engage in efforts to improve affordability of healthcare. Now I'll go over what the spending target is not. First, it's not a cap on prices or a price reduction. A spending target looks forward towards managing growth. It cannot roll back or cut prices. Next, it is not a measure of internal costs or operating expenses of healthcare entities. Instead, we are measuring payments from payers to providers for the cost of medical services that are covered benefits. Lastly, the spending target is not a single solution to addressing healthcare affordability challenges within California. The spending target provides critical information and data to inform other OCA policy or broader state initiatives to improve affordability and access. So now I'll take us to the next slide, which is our quarterly work plan. So the director covered our agenda for today's meeting. So I'll take us what's ahead for May. If the board decides not to act today on the action item for sector targets, the board can consider it at May's meeting. In May, we expect to provide an update on new capacity we're building in OCA on pharmaceutical policy and programs. This is due to the complexity of the pharmaceutical sector and its impact on healthcare spending. The dedicated staff resources would build analytical capacity on the pharmaceutical market, including data analysis, policy research, and recommendations for policy action. As part of the annual reports that OCA will publish on spending performance of healthcare entities and cost drivers, OCA will include relevant data and analysis on the pharmaceutical sector and include recommendations for state policymakers. In May and June, we'll provide updates on the ongoing work to define behavioral health services and progress we're making to recommend an investment benchmark. In May, we'll preview key findings from the baseline report on healthcare spending for the 2022 and 2023 calendar years. As a reminder, the report will be published before June 1st, and we hope to share further details at the May Advisory Committee meeting and a subsequent board meeting. I'd flag that we have placeholders for June as we continue to plan on what content to bring to the board and the public for discussion. And then taking us to the next slide. So future topics beyond June 2025. By this summer, we want to start some discussions on enforcement of the spending target. We'll provide an overview and begin discussion on reasonable factors for exceeding the target. This has been an ongoing discussion, and we've received several public comments on potential factors that may be outside of a healthcare entity's control, such as the cost of certain specialty drugs, and others raise investments that they're making to deter future costly care. So we'll be having a public discussion on those reasonable factors. And then moving on to promoting high value system performance. I mentioned the work of the investment benchmark. We hope to have a recommendation to the board this summer so that the board could potentially take action on approving a benchmark. And then we'll introduce the equity adjustment and the quality adjustment provisions that are included in the OCA statute and the work that we've done to date so that we could discuss it with the board. And then moving on to market consolidation. We'll continue to provide updates on material change notices received, transactions receiving a waiver or warranting a cost and market impact review, and the amount of time that we take to review those notices and provide healthcare entities either a waiver or a notification that a CMIR is ordered. So I'll take us to the next slide, which is our slide formatting key. Just as I do at every public meeting, I'd remind the board and the public that the statute denotes different roles for OCA and the board. The yellow areas are content that OCA brings for discussion with the board, as well as to solicit comments from the public. The yellow areas are areas where OCA has decision-making authority, while the green arrows are areas where the board has ultimate decision-making authority. And I'll turn it back over to the chair to facilitate discussion.
Thank you very much, Deputy Director. Questions from the board? Dr. Khan.
Thank you so very much for that presentation. Pagani, one of the questions I have is that obviously our work generally is looking forward, but we've also made certain decisions in the past. So a year ago, we decided to adopt the 5-year run for the cost targets. And while we're still collecting data from the various health entities, right, to figure out where they are, we did make certain assumptions, or we had certain rationales we established for establishing those cost targets. And I think what would be helpful is that since it's now a year from now, to at least look at, for example, median household income. How much did it change in 1 year? If we take our 20-year run, okay, now it's a year later, so now we move it up. How does that each year? So, I mean, since we're up to that year, even though we did a 5-year, it's good to, and it doesn't mean that we have to spend a lot of time on that, but we should also look at the underlying assumption, like what the inflation rate has been, right? What the medical inflation rate has been. What has what is the average, the median household income, which is what we're basing the cost target on. How has that changed in the past year? And therefore, if you look back 20 years now from this year versus last year, how might that have changed or not? Maybe not a lot in 1 year, but I think each year as we look over time, that's going to be important because obviously so I was hoping that we could at least have someone could just run those numbers and show us the graphs and or at least, and even if it's just in communication and we have a brief time for just discussion where I'm not talking about reopening the cost targets. I'm just saying that it's good to look at our assumptions and see how the trends are going on those things as we're looking at, obviously, as the data is going to come in the future for looking at how the various health entities have met those cost targets.
Thank you, Dr. Pan. So I think a good forum for those types of questions could be when we review the baseline report. So we'll talk about the trends we're seeing for 2022 and 23 data, and then we could, alongside the presentation of the report, we could also circle back on those questions that you just raised.
Okay, and when do you anticipate that?
It would either be at the May meeting or the June meeting.
Okay, all right, no, that's good. All right, thank you.
Not seeing any other questions from board members. We'll go ahead and open up public comment for this item.
We will now recognize members of the public for comment on this agenda item. Please reserve comments on other agenda items for the general public comment period. To ensure equitable access to verbal public comment, we will alternate between members of the public present in this room and those attending virtually. Those in this room may line up at the podium. Those attending virtually who want to comment should click the raise hand button. Those dialing in can press *5 to raise your hand. It will track the order in which the hands were raised. During the public comment period, you will be unmuted when it is your turn. We also invite you to provide written comment at the email address provided on today's posted agenda for the meeting. Please keep your comments to 2 minutes or less so we can hear from as many members of the public as possible. Please note that while the Healthcare Affordability Board is committed to communication and transparency, board members and staff will not be responding to public comment. Additionally, the board may not discuss or act on any matter raised during the public comment period that is not included on the meeting agenda, except to place the matter on a future meeting agenda. Looking to the podium, seeing no one at the podium, looking virtually. Seeing a hand raised. Jay, go ahead. Jay, we are unable to hear you on our end. You might need to unmute on your end.
Can you hear me now?
Yes, I can. Great. Thank you. Go ahead.
Perfect. My name is Jay Krishnaswamy. I'm the CEO of Doctors Medical Center in Modesto, known locally as DMC, and I appreciate the opportunity to speak today. DMC is the hub of the Central Valley Doctors Health System that includes Emmanuel Medical Center in Turlock and Doctors Hospital of Manteca. Our three hospitals provide a disproportionate share of care to Medi-Cal and other underserved patients across the Central Valley, proudly serving as a safety net healthcare system for 8 separate counties. You have our data. Each year, we accept over 4,000 trauma transfers, plus NICU, STEMI, and stroke transfers for critical services that do not exist together at any other Central Valley hospital. We care for over 87,000 Medi-Cal and over 6,000 self-pay uninsured patients, and also provide nearly $230 million annually in uncompensated and charity care. You have received letters of concern from elected leaders and our local healthcare partners, such as federally qualified health centers and county providers. All share our alarm over proposals before you today. We must be very clear. We oppose the imposition of high-cost hospital spending targets and urge this board to reject them outright. This spending target framework does not recognize all payer mix and fails to acknowledge the daunting challenges facing all safety net hospitals, who, like DMC, face the combination of serving an extremely high Medi-Cal population coupled with extremely low commercial patient volume. This cannot be overstated. By any public policy rationale, this is a fundamental and glaring omission in the methodology, because the simple fact is that all hospitals are not the same. We
2
urge
minutes.
your board to properly examine how California hospitals would rank if such a profile included an all-payer case mix, the truest and most neutral possible baseline analysis. It is confusing that while OCA's mandate is to protect access, enhance quality, ensure equity, and stabilize our workforce, your proposal will likely do the opposite. It is also completely misleading to suggest these targets are not caps. Insurers are already seeking to leverage your previously adopted statewide spending targets. So where is the public's interest in adopting a framework pressurizing safety net hospitals to reduce spending by 50%?
2 minutes
More
and 30
what
seconds.
all other hospitals must attempt to meet. Adopting your high-cost framework will have unintended consequences, forcing reductions in capital investment, hospital capacity, services, and staffing, limited access to quality care for the most vulnerable. You know our mandated capital investments include tens of millions in seismic retrofitting cost, yet those have
3
been
minutes. Reminding
committed
members of the public to please limit your
OCA's
comments to 2
methodology.
minutes if possible.
The math will not add up. Finally, the future of the Medi-Cal program is at an inflection point. The state is struggling to fully fund the program, and potential federal changes will also negatively impact the care for 15 million Californians. We urge your board to reject any new or lower annual spending targets for hospitals. To be accurate,
3
it's
minutes
vital
and 30
OCA
seconds.
include a hospital's full payer mix in any and all of its methodologies going forward. If not, this flawed methodology will harm the health care of the very people whose access to care we should be protecting. Thank you.
Thank you. As a reminder, we are just taking public comment right now on the executive updates. That is the agenda item that we're focused on. So this, if it's related to the executive updates.
Looking virtually, seeing no other hands raised, looking to the podium, seeing no one at the podium. That concludes public comment on this item.
Thank you. And I will ask now for us to take roll.
Dr. Sandra Hernandez, Secretary Kim Johnson,
Here.
Richard Cronick,
Here.
Ian Lewis,
Here.
Elizabeth Mitchell.
Here.
Dr. Richard Pan,
Present.
Don Molds,
Here.
6 present, 1 absent. We have a quorum.
Thank you. We will now move on to item 3, action consent items. And I'll turn it over to Deputy Director Begani.
So we just have the March meeting minutes. The minutes and written public comment have been distributed to board members and the public in the meeting materials.
Thank you. Is there a motion to approve the action consent item 3A?
Move approval.
Motion and a second.
Second.
Thank you. We will now invite public comment.
We will now take public comment on this agenda item only. Please limit your comments to 2 minutes. For those attending virtually, please raise your hand. Those in the room, please step to the podium. Seeing no hands raised virtually and no one at the podium, that concludes public comment on this item.
And we will call the roll.
Dr. Sandra Hernandez, Secretary Kim Johnson,
Aye.
Richard Cronick,
Aye.
Ian Lewis,
Aye.
Elizabeth Mitchell.
Aye.
Dr. Richard Pan,
Since I wasn't present, I'll abstain.
that's 4 ayes, 1 abstain. The motion passes.
Thank you. As Director Landsberg started at the top of the meeting, we're going to take now informational items 5A and 5B out of order, beginning with an update on hospital outpatient spending measurement. Deputy Director Begani and Mary Jo Condon from Friedman Healthcare will present on this item.
Thank you, Secretary Johnson. So I'll take us to the first slide, which is our goals for today's update. So today we'll share a few updates on how OCA is refining methods to measure outpatient hospital spending. This work is key to ensure that we have a standard approach to measuring hospital spending across both inpatient and outpatient settings. Next slide. So hospital spending essentially reflects 3 components: price, volume, and intensity. The number and types of services hospitals provide will affect spending, as well as the prices of the services provided. And on the next slide, I just want to go over some terminology for today's presentation. Case Mix Index, or CMI, is a measure of complexity for inpatient care, reflecting case severity and resource use. For outpatient care, we will need a similar measure. Throughout today's presentation, we will refer to this as the Outpatient Intensity Adjustment, or OIA. Both the Case Mix Index and Outpatient Intensity Adjustment serve as indicators of the relative complexity and resource demands of the services provided. Next slide. First, I'll discuss OCA's provisional approach to measuring inpatient hospital spending. So we shared this this has been an ongoing discussion since November. We're essentially applying a case mix index to inpatient discharges. What we do is we multiply inpatient discharges by the case mix index, which yields case mix adjusted discharges, or CMADs. The case mix index indicates how many resources were needed to deliver care compared to a standardized unit of service. So it's designed to count inpatient discharges in a similar way, whether a hospital is focused on less acute community care or more intensive tertiary services. We then divide inpatient net patient revenue, or inpatient NPR, by CMADs to arrive at a per unit measure of inpatient NPR per CMAD. This allows us to better isolate price for hospital services by accounting for how much and which services hospitals perform. On the next slide, I'm going to provide an illustrative example to help some of the numbers and the math come alive. So here's a step-by-step view of the calculation. In this case, we multiply 1,400 discharges by a 1.25 case mix index to get 1,750 case mix adjusted discharges, or CMADs. We then divide the inpatient NPR of 35 million by the 1,750 CMADs. This gets us a value of $20,000 inpatient net patient revenue per CMAD. So this metric helps us understand revenue per unit of intensity adjusted care. On the next slide, I'll shift gears to how OCA will approach measuring outpatient hospital spending. I do want to acknowledge that outpatient spending is harder to measure. The care is often more varied and more distributed across providers. And also there's less information available, especially in the public domain. A reliable adjustment factor is needed to capture outpatient service intensity for hospitals. Next slide. So I showed this slide a few minutes ago when I went over the key terms. I just want to highlight that the focus of today's presentation will be on outpatient measurement in particular, and outpatient intensity adjustment. Next slide. So this slide provides an update on data sources that have been used to date. The provisional approach utilized the hospital financial data, which we refer to as hospital financial data, or the formal term is AFDR, or Hospital Annual Financial Disclosure Reports. And then there's also a separate data set referred to as the patient discharge data, or PDD. So the PDD collects all inpatient discharges and ED visits, as well as visits at ASCs, or ambulatory surgery centers. So the strategy to date using these two data sets has worked well for inpatient service, but it's not as straightforward for outpatient care. To develop an outpatient measure, we need more refined data that provides claim level or encounter level detail. The options provided today build on feedback from our previous discussions on this topic and leverage existing data sources. Next slide. So the Healthcare Payments Database, or HPD, which the board and the public received a briefing on at the March board meeting. That could be combined with hospital reports to close this information gap and support development of an outpatient measure. They offer complementary data. The hospital financial data provides net patient revenue and visit counts, both for inpatient and outpatient care. So while case mix index can be found in the patient discharge data set, or PDD, the HPD, on the other hand, offers claims and or encounter level detail needed to calculate outpatient weights for the outpatient intensity adjustment. You know, in this way, we'll have the revenue, the intensity, and the volume to develop parallel measures for both inpatient and outpatient services. Next slide. So I want to provide an illustrative example that shows the similar logic being applied to develop the outpatient measure, as I showed earlier for inpatient. So in this case, we see 10,000 outpatient visits and an outpatient intensity adjustment of 1.3. These are multiplied together to arrive at 13,000 adjusted outpatient visits. If we divide a hospital's 6.5 million in outpatient net patient revenue by 13,000 adjusted visits, it equals $500 in outpatient NPR per adjusted outpatient visit. So kind of in summary, we're trying to get to that same level of measurement where we have a per unit measure both on the inpatient side and the outpatient side. Next slide. So based on feedback from the board, stakeholders, OCA convened hospital spending measurement work group. OCA has further explored additional options to more accurately account for changes in outpatient service intensity over time. There are two options that provide us with outpatient intensity adjustment. The first is APC weights, or ambulatory payment classification weights, and 3M enhanced ambulatory patient groupings, or EAPGs. Both options would use HPD claims and encounter data to assess relative resource needs for a hospital. So I'm just going to focus on option one for now, which are the APC weights. These are based on Medicare outpatient prospective payment system weights. And so the Medicare program reimburses hospitals for outpatient services based on a predetermined rate, and CMS publishes the APC weights through the Federal Register. APCs are used to group services and determine payment amounts. In this case, we would leverage APC weights to determine the outpatient intensity adjustment. The second option, EAPGs, are a third-party tool developed by 3M. So this is a proprietary tool. EAPGs classify outpatient care into patient groups and categories based on key procedures and primary diagnosis code. EAPGs provide payer-specific weights, including a commercial-specific weight. So the key distinction between these two options is that one is focused on a Medicare population, which is option one, versus the 3M EAPG option reflects a fuller population and includes payer-specific weights, including for commercial. And I'll take us to our next slide, which is considerations of methodology options. So in comparing these two options, I'd first note that both can be applied to claims and encounter data in the HPD to develop weights. There are a few differences, however. As I mentioned earlier, APCs are an open source data set. It's more transparent as Medicare uses this to pay providers. However, there are some limitations with APCs. They're not as meaningful for hospitals with fewer Medicare patients, such as hospitals that provide more maternity services or children's hospitals. EAPGs offer more refined measurement of resource intensity and are based on all patients. However, it is a proprietary tool and will be less transparent than the Medicare grouper. And then I'll take us to our next slide. So this slide outlines how we would apply an outpatient weight to each hospital under a scenario where we're using HPD claims and encounter data. So regardless of which option we use, option 1 or 2, what we would do is apply the grouping software to each hospital's outpatient claims in the HPD. We would, in step 2, we would sum the relative weights across claims and encounter data for each hospital. Step 3, we would produce a single outpatient weight, so essentially a weighted average for each hospital. And then step 4, we would use the outpatient intensity adjustment to enhance the HCI hospital financial data. So as I mentioned earlier, the hospital financial data includes visits and includes counts of visits by different categories such as ED visits or other types of outpatient care. So we would essentially be multiplying the outpatient visits reported in the HCI financial data by the facility's average relative weight or the outpatient intensity adjustment. So this outcome would ultimately produce that adjusted outpatient visit metric that I mentioned earlier. And then just to illustrate some of the math involved in this, so we multiply outpatient visits by the outpatient intensity adjustment, regardless of whether we use APC or EAPG weights. That's going to get us our adjusted outpatient visit. And then we would take the outpatient NPR data from the HCI annual financial data and then divide it by adjusted outpatient visits. And then that would get us that per unit measure of outpatient care that we're looking for. The next slide goes over some of the work we're going to do to validate the use of the HPD for this purpose. So validation is essential to ensure that HPD data accurately reflects our desired population. It's important to know how much data is available and whether it reasonably represents the population. By comparing other data sources to the hospital financial data, we can assess the completeness and representativeness of the HPD data. Next slide. So to date, we have performed correlation analyses to help confirm the comparability of HPD for measurement purposes. The goal is to ensure that the HPD is directionally correct and is a representative sample of our of hospital utilization. To do this, we have compared HPD data to several publicly available data sources. You know, here at HCI, we have access to inpatient case mix index values and hospital financial information. So that's where we're initially focusing this comparability analysis. So in the first step, as part of some initial steps, we have compared the HPD to the hospital financials on an aggregate level, as well as a facility level. We then use the data to perform a correlation analysis to assess the representativeness of the HPD compared to hospital financials. In the next two steps, we calculated case mix index values from the HPD and the PDD for each payer type as a whole. And then last, we took these case mix indices and compared overall and facility-wide and by each payer and perform additional correlation analyses. And on the next slide, just want to provide some background information on what's included in the HPD. When comparing the HPD to other data sources, including the hospital financial data, what we found is that the HPD is a representative sample of hospital utilization. In a recent report to the legislature, we included details listed here that the HPD captures about 80% of California's healthcare experience, specifically 82% of California's total population and 89% of California's insured population. This includes the HPD having 90% of statewide ED visits, 85% of inpatient admissions, 76 to 89% of out-office visits. I do want to note that the HPD is not 100%. This is because not all patient populations or payments are included in the HPD. For example, self-pay, the uninsured, most of the self-insured, and smaller commercial plans with less than 40,000 lives. Looking across 4 years, it appears that the HPD data has the same aggregate revenue and utilization trends as reported in the hospital financial data, suggesting that it could be a reliable source of data for the use case of outpatient intensity adjustment. I'll take us to our next slide. So it'll be important for OCA and HCI to continue validating the HPD across payer types and service lines, focusing in on the distribution of patients by age and sex, and assessing per unit charges. These validation steps will give us further confidence that we understand the patient population represented in the HPD, help identify any gaps, and consider variations across care settings. And then taking us to our next slide. So these are some of the challenges faced by all payer claims databases nationally and in California. As I mentioned, there's the data gaps for certain populations. States have overcome some of these limitations by understanding the magnitude of the gaps and addressing them systematically. For example, by pooling information for facilities with less data available. We're considering these limitations and are factoring them into our analyses and recommendations. Next slide. So I do want to provide some information on a timeline. We are continuing to undergo efforts to validate the use of the HPD and to establish confidence for using it for this purpose. We anticipate in the coming months applying weights and generating results for the outpatient measure. Following development of the outpatient measure, we plan on reconvening the hospital spending measurement work group to share and review our findings beginning this summer. And then taking us to the last few set of slides, beyond the HPD, it's important to acknowledge that there are other sources that could be leveraged to develop an outpatient intensity adjustment. We're evaluating these options for feasibility and usefulness in the event we need to leverage a different data source besides the HPD. Next slide. So these options include new reporting from payers or hospitals. I'll take each option one by one. So under option A, this would be what I essentially covered, which is to use existing data in the HPD. This would provide us the advantage of being less resource intensive and creating a consistent, verifiable method for determining resource intensity. However, the drawbacks include that it may not be representative of all patients, as it does not include self-funded plans and some non-claims payments. Data cannot be resubmitted or revised, and matching claims to individual facilities can have some challenges, potentially producing non-random discrepancies between facilities or across years. Option B involves collecting new data from commercial health plans. It has the advantage of aligning with current reporting cycles and requirements for reporting on total healthcare expenditures and other data submissions that plans make for HPD reporting. The plans may be better positioned to report outpatient waits. However, some drawbacks of this option include, similar to the HPD, limitations on the patient population. It would require staff to collect, validate, and compile data from health plans, approximately 10 organizations. It also introduces new reporting requirements for health plans. Not all health plans will be able to report outpatient waits, and validation of the reported waits would prove difficult. Option C would be new data collection directly from hospitals. It has the advantage of including all patients and could be aligned with current requirements of hospital financial data. The drawbacks include less expertise, hospitals having less expertise in developing weights and limited use of grouping tools among hospitals. OCA staff would be required to collect, validate, and compile data from all hospitals, which is approximately 443 organizations or facilities. Again, it would be a new reporting requirement for hospitals, with some unable to compile and report these data. As with option B, validation would prove challenges, though hospitals could attest to the accuracy of the submission. Next slide. So if we were to pursue a new data collection, it would require a development phase to define data collection requirements. There would be an implementation phase to coordinate and collect the data, and a validation and measurement development phase to produce results. Ongoing, this would require some additional infrastructure to operate and maintain data collection. And then lastly, implementation would depend on how quickly things go through the regulatory process to promulgate new data collection regulations. Next slide. So for this approach, a phased timeline is proposed. Planning, implementation, then validation and refinement would take anywhere from approximately 1.5 years or just under 2 years. Final timing would depend on approach and complexity of data collection and regulatory requirements. So that wraps up the update on OCA's provisional approach for measuring outpatient hospital spending, and I now turn it over to the chair to facilitate discussion.
Thank you very much for that presentation and for the considerations in both the options that you presented as well. So appreciate the work that's gone into that. Questions from the board?
Thank you very much for that presentation and appreciate all the hard work in doing this. We know that this was a big missing piece in looking at the hospital piece and really appreciate the work that's being done. I guess a couple of questions. First of all, the HPD basically you said covers 80%. The question is that the remainder, how different are they from the 80% that's in there, right? And to what degree that swings. So self-insured plans, I would think. I mean, obviously, and there's other people perhaps more expert than I would think would probably be fairly similar to the other. I mean, we don't have the data, but they're, the people, their employees, et cetera, right? So you would think they would probably be pretty similar to the 80% we did collect. I don't know what percentage is like the uninsured or so forth. That might be a bit different. So in other words, of the 20% that's remaining, just sort of getting an idea about, some of the reasons why they might not be in there would still make me think they're fairly similar to the 80%. And then how much is left that might be different? And I'm not sure exactly how much different they are, but you could think they might be a little different. So that might be helpful, but 80% is pretty good, I guess. And then I guess the other thing in terms of APC versus EAPG, you did mention that the Medi-Cal program uses the proprietary system, and I presume, but perhaps you can clarify, is that because of the data, it's sort of, I guess, I won't say missing, but perhaps less robust coding for things like children and maternity and so forth. I'm just curious as to why, I mean, Medi-Cal decided to go with the proprietary, with EAPG. So the rationale for Medi-Cal choosing that versus, now maybe, I presume they looked at APC, but seems to me like if we are more aligned with an existing agency's decision-making, not to say we completely defer, we should take a look at ourselves independently. There may be certain advantages, but I don't know if you see there's advantages to us lining up with Medi-Cal using the same, what do you call it?
Yeah, that's our suspicion that's why DHCS is using it. We definitely want to reach out to them to confirm that. You know, HCI overall does have a preference for using open source tools, but we do recognize the limitations with the Medicare weight. So we do want to do a full exploration of the EAPG weights to see what the results are with that data.
It would be helpful to understand why Medi-Cal chose the APG over APC or other options they might have looked at. Yes.
Yeah, definitely. We'll circle back on that.
Elizabeth.
Thank you, and thank you for the presentation. I know I've mentioned this before, but it may be even more relevant in response to Dr. Pan's question about the 80%. The CAA data includes actual pricing, and it may sort of reduce the sort of mathematical gymnastics required to actually figure that out. So we are using it now. It is very complementary to the claims data. It includes commercial pricing. And there is a lot of movement in the administration to increase enforcement. We've had some trouble with hospital reporting and outpatient reporting, but that is getting significantly better and usable. And I think for a future data source to complement the claims that you already have, that could fill in a lot of the gaps. So I don't know if you're considering that.
Yeah, thank you, Board Member Mitchell. So I think the suggestion is that potentially looking at the transparency data and seeing how aligned it is with commercial prices or the fully insured commercial prices.
Well, you can actually find out the actual prices and
Okay.
charges. So it's, and it shows the negotiated rates with the plans. It's basically, it will fill in some of the blanks that I think there may exist. I think this is an excellent start and very reasonable, but as you move forward, trying to get even more visibility into the charges and prices, that could be very helpful.
Thank you.
Ian, please.
Thank you. A couple of things, just in response to Dr. Pan's comments about the 20% missing in the HPD. I've heard anecdotally that of the self-insured purchasers who run their claims through TPAs, that many of those TPAs adopt kind of an opt-in model, but that some of their staff, even those connected to PPOs, sizable PPOs, are unfamiliar with the existence of the HPD. And so it underscores for me there's some public education that group purchasers, as well as some of the PPOs, could be doing to help motivate more participation. Secondly, I had a question about the outpatient methodology, but in interest of full transparency, I have with regard to 3M Health Information Systems, I have a family member who was a senior staff person with 3M and may still derive some income from them. So just wanted to, and I worked briefly in connection with 3M about 25 years ago. But I had a question about the prevalence of alternative payment models in hospital outpatient settings. I really don't have a sense if they exist or if they are prevalent at all, and does that affect our ability to use either APCs or EAPGs or anything else?
Yeah, I think the focus would be on more of the utilization data to calculate those weights, and not so much on whether they're engaging in alternative payment models.
But where there are alternative payment models, we're confident we capture the utilization data.
So the HPD would, so like if a hospital is engaged in an APM, they would still bill normally as they do, unless it's a non-claims payment, a capitated arrangement or something like that. But the claims and encounter data should still be coming to the HPD.
Rick?
Thank you. I second Dr. Pan's compliments and thanks on the progress being made. We heard a couple months ago about the difficulty in attributing claims to facilities. We heard last month from Mike Valley about some of that, and it's wonderful to see that you make progress on that. Just two comments. One, I appreciate the validation efforts, and thank you for that work. I wasn't sure if part of that was comparing the counts of visits from the HPD with the count of visits in the annual financial disclosure reports. And if that isn't something you've done, I would encourage you to do that as part of validation. Hopefully those visit counts would be relatively close. And then second, just a small, you raised a concern, which I would share some, about the use of the Medicare weights on the APCs. It would be possible, maybe not for the first year, but to use the HPD data to develop weights for the APCs. And I know we had a discussion many months ago about the use of Medicare weights in computing the CMI, and heard that it probably didn't make much difference whether we use Medicare weights or kind of homegrown weights. The same may be true for the APCs, but it would, if we go the APC approach, it would probably make sense to put some effort into trying to see whether the weights, the Medicare weights, are appropriate, or whether homegrown weights would be better.
Yeah, thank you, Board Member Kronik. So I do want to clarify that the validation work, we have started some of it, and we're going to continue to do more. So it's not complete. And then regarding the attribution process of linking claims and encounter data to facilities, that's also underway as well. So we were able to get some head start on that through kind of leveraging some resources about hospital NPIs. So we're continuing to refine that, as well as kind of replicate some of the linkages that others have done, such as RAND, for the hospital price transparency work. And then going back to your question about the utilization counts, those we're also doing that, and did find that on aggregate, not by individual facility, that the trends do look similar in revenue and utilization for both the HPD and the hospital financial data.
Don?
Yeah, I was just going to add, as you were thinking about the validation work, we, CalPERS used the Healthcare Cost Institute in 2019 and 2020 to do an independent, it was essentially a benchmarking activity. They were looking at spending trends in pretty sophisticated ways in California and in and outside of hospital settings. And then we were using that to benchmark what we were seeing in the CalPERS data. So just another source to think about as you're as you're thinking about that work. And of course us, but I know you're already on to us.
Yeah, thank you, Board Member Mold. So when you use HCCI, were you looking at kind of aggregate trends, or were you kind of looking at facility-specific analyses?
So we were looking at counties, but my understanding is that they're able to get pretty granular. This was what now 5+ years ago. So I don't, and I think their data resource has changed. I think United is not in their data anymore, but Kaiser is, and a lot of the other major insurers are. But they were able to give us just pretty close to any view that we were looking for. At the time, we were primarily looking at county-specific data, but I think exploring with them the possibility of getting to a facility level is probably worth doing.
Thank you. We are now going to invite public comment on the measuring hospital outpatient spending, item 5A.
We'll now recognize members of the public for comment on this agenda item. Please keep your comments to 2 minutes or less so we can hear from as many members of the public as possible. If you're in the room, please step to the podium. If you are online, please raise your hand. Looking to the podium, please go ahead.
Beth Capel for Health Access California. First, we're very pleased to see the use of the HPD data. Some of us who were involved in developing this effort had looked forward to the moment when the HPD data could inform it. Second, we have a third option to suggest on the alternatives. We, in those who have more technical knowledge of the proprietary approach will have to weigh in. We would suggest using the Medicare weights for most things, but using the 3M proprietary approach, because we have for maternity and children's services in order to appropriately weight it. We think it's important to recognize the importance of those services, but we have a strong preference for non-proprietary software, which we are pleased that HCI shares, and we wish DHCS did as well. With respect to the data that's collected, we are fortunate in California that the self-insured universe is smaller than in most other states, and we are also fortunate that the HPD requires those self-insured plans regulated at the state level, such as CalPERS and the VIBAs, to submit data to the HPD. So we continue to worry about the reliance on charges in some of these measures, and we'll look forward to the hospital measurement work group to have further discussion about that. We would, as the law requires, encourage reliance on existing data if at all possible, and not imposing new data collection requirements unless absolutely necessary. Thank you.
Looking virtually, seeing no hands raised, back to the podium.
Ben Johnson from the California Hospital Association. Appreciate the discussion, which really shows how much more work is needed to determine how OCA will measure 40% of the services that hospitals provide. We second questions from Dr. Pan and Dr. Kronik and ask OCA to reconvene the hospital spending and measurement work group to incorporate into the policy development the expertise of the hospital leaders that do this work every day. And we ask the office to take all appropriate steps to ensure that the methodology is transparent and validated. And then finally, we do urge the board to finalize this outpatient spending methodology and measure spending changes over time in accordance to it prior to adopting targets that aim to constrain the growth of the same spending. Thank you.
Thank you. Looking virtually, seeing no hands raised, reminding members of the public that are dialing in to press *5 to raise your hand. Noting for the record, we have about 120 virtual attendees at this time. Looking back to the podium, seeing no one at the podium, that concludes public comment on this item.
Thank you very much for that discussion, and we will look forward to more on that topic. We're going to now move on to item 5B, the follow-up to the sector target methodology and values, including the summary of public comment, and it was very robust, and we'll turn everyone to the information online if you'd like to see all of that public comment that's been compiled, but appreciate the team compiling that into a summary as well. So I will turn it back to Deputy Director Pagani and also CJ Howard.
Thank you, Secretary Johnson. So in this section, we'll, as the Secretary mentioned, we'll provide some feedback on the public comments received. We also met with one hospital as part of the hospital engagement meetings, and we'll provide feedback we received from that meeting. And then CJ will review the board's discussions on the sector target methodology to date. And then I'll follow up with some broader considerations for the board as it discusses hospital sector targets. So I'll take us to our next slide. Last month we met with one hospital, and because we anonymize the feedback we receive, we don't have a list of names. Because it was only one hospital that we met with in April, but their feedback included that high quality surgeons and nurses command top of market wages. They indicated support but note that it does not account for all elements of patient care, cost, or complexity. They recommended that OCA consider a community complexity adjustment, which considers shortages in other service areas or care settings. They gave examples of skilled nursing facilities and long-term acute care facilities, and how deficits in those types of facilities in a region may impact hospital costs. OCA should consider other they also suggested that as part of this community complexity adjustment, that OCA consider other investments that a hospital may make in expanding community care and access. Examples of these investments include home health agencies, skilled nursing, outpatient settings, physician organizations. And they also recommended that not all entities in a region or a community make commensurate investments in the regional health care infrastructure. To kind of elaborate on this, the entity we met with suggested that they're doing things in their region that other competing hospitals are not. OCA should consider where an entity invests its resources. That is, does an entity reinvest in the local community, or are revenues funneled out of state? OCA should evaluate more than cost and assess the value a hospital adds or provides to the community or region. So that wraps up the hospital feedback slide. I know we're going to go into an extended review of the public comments, so I just want to pause in case the board members have any reactions to this feedback.
I appreciate the report on the meeting, and I think it speaks to some of the challenges that we're going to have in trying to, develop policy across the state, and each hospital and each community is a bit different. It actually this feedback sort of makes me reflect on the fact that in the United States, and I'm teaching our health policy class at UC Davis. I was just talking about this recently in class, is that we often channel a lot of our social services through our healthcare system, because people are generally more willing to spend money on the healthcare side than on the social service side. Just, I think it's a political reality in the United States. As someone who's used to chair the budget subcommittee, and I'm sure our secretary is quite aware of this as well, having directed the Department of Social Service. And so when I see this feedback, and I hear what they're saying, I think it's a little challenging is that what I hear is that the hospital is sort of picking up some slack in the community, or at least that's what they believe they're doing, that might exist in community social. I don't know which area this is and how robust or not the social services are in the county and their willingness to invest, et cetera. And so, and it's actually interesting because when we talk about social determinants of health, if you were running the main healthcare institution and you see there's a gap and you'd say, hey, this would also save us money on the healthcare side, shouldn't we put our money into the social service side? What that does is that, and we've of course heard from people coming here, that really instead of placing the burden on, I guess, the taxpayers or the broader population, it puts the burden more on probably the people paying for the commercial insurance, right? And I think we need to kind of acknowledge that. What that does mean is that, and of course, those, commercial plan and the people who are paying into this commercial plan. So all the working people who are paying into this are essentially subsidizing or supporting the social, this is part of, I'm not saying the entire, but part of the social service infrastructure in that community. So instead of more broadly, this more narrow base. And so one of the things that as we're making these decisions, at least as I reflect on it, is that, and I hear what the hospital, that this hospital is saying, and many other hospitals, as we're looking through the different comments, is that we're asking, and this may be a reasonable thing, some people say it's a very reasonable thing to do, is say, guess what? It's not your job to do that, and that community is going to have to figure out another way of doing it. And so what happens is, and certainly as a healthcare provider myself, as a physician, I can see the frustration of someone who is a healthcare person who says, hey, you know what? If we could only put some resources into this, it would be cheaper than me having to deliver healthcare services. But you know what? But no one else is really stepping in the community to actually do that. And so maybe I can try to do that myself or put some resources there, but where are the resources coming from, right? And I think that becomes the bigger challenge. So realizing we're the Office of Healthcare Affordability, also recognizing that the people who are really supporting it when we do something, when when hospitals are picking up that gap is primarily, it's basically the payers who pay into the healthcare system, and more specifically, given the fact that the public payers tend to be less, it is the commercial pay, basically the people who are paying for commercial insurance who are probably picking up a disproportionate burden of that. We are challenging those communities to say, guess what? Your hospital, who you've normally turned to and may have done so for decades, is not going to do this anymore because we're going to make it much harder for them to do that. And therefore, you need to find some other way of essentially getting those resources, right? Whether it's through other entities, including government, your local government, and as well as getting your state representatives to support more money that way at the state level to get to your local government to make that happen. So I guess a long speech, but it's an observation I think I need to make given what the feedback of this particular hospital, whichever it is, I don't know which one it is making.
Elizabeth.
Thank you. And just in response, and I am not weighing in on the merits of this in any way, shape, or form, but in all of the federal proposals right now, they will be limiting housing and social needs in Medicaid coverage anyway. So it wouldn't be OCA, it would be the feds. And again, I'm not weighing in on that. I'm just saying that I think there's going to be changes federally.
I think there are going to be changes federally to be determined. Ian, please.
Yeah, thank you, Dr. Penn, for putting it that way. It made me wish I had taken your policy class. But yeah, that sense of shared responsibility for the community good here is a conversation I hope will really become quite robust. I think underlining everything that we've been talking about these many months on this subject is, the fact that the commercial market, particularly employment-based plans, are paying 2 to 3 times on average, and in some egregious cases, 5 or 6 times what Medicare says is a break-even number or close to it. So, certainly the commercial side is carrying its fair share. I think the discussion around kind of at least the outlier thing that we'll get to is underlining that the commercial side can't be simply a blank check anymore to underwrite those services, and will prompt that kind of discussion, and I look forward to it.
Not seeing any other questions or comments from the board. You can free to continue.
Thank you. So I'll be taking us to slide 45. So OCA received, if we could advance. OCA received 328 public comments related to its sector target recommendation. This included 247 letters from members of the public and 81 letters from organizations, groups, or healthcare entities or hospitals. Comment letters came from individuals, unions, consumer advocacy groups, purchaser organizations, individual hospitals, a health plan, specialty care, and hospital associations, among others. The summary slides that we'll present are grouped into the thematic categories listed here. CJ, Howard, and I will alternate between these thematic categories. I do want to note that this is a summary. It's not inclusive of all comments received. Please refer to the full set of public comments that were distributed on the HCI website. So I'll take us to our first thematic category of the timing of sector targets. We begin with the following concerns about the timing of the sector targets. The first comment related to the statutory deadline for sector targets is not until 2027 to define initial sectors and 2028 to set sector targets. The statute allows for more time to develop sector target methodology and the target. OCA has yet to finalize a methodology for measuring hospital spending. There are also some concerns about the lack of historical data review with respect to the hospital measurement approach and other sectors of healthcare in California. Before defining healthcare sectors, all stakeholders would benefit from a comprehensive analysis of spending across various segments of the healthcare industry, identification of high spending growth areas, and a meaningful assessment of spending drivers. Another comment reflected that OCA needs time to study the high cost of trauma centers and impact of operating trauma centers on hospitals' finances. One commenter noted the need to perform analysis or review of the potential consequences of the sector target proposal on access, quality, equity, or workforce stability. Other comments pertain to OCA delaying finalizing the hospital sector-specific targets until after both the adoption of the federal budget for fiscal year 2026 and when OCA has completed an analysis of federal budget impacts on California's healthcare providers. And lastly, another comment noted that the potential for as much as $880 billion in cuts to Medicaid that could reduce federal Medicaid eligibility or financing, and that OCA should delay until the impact of federal Medicaid changes are known. So I'll move on to comments in support of the timing of sector targets. There was a comment about many or most of the hospitals on this list have been known as high-cost hospitals for decades. Those who counsel delay are those who profit from the existing system. not the consumers who suffer as a result of high healthcare costs. Consumers want change. There's a comment noting that consumers are in a dire situation that demands immediate attention. There was support using statutory flexibility for moving forward now to set lower cost growth targets for high cost hospitals. A comment noted that OCA's recommended pace is cautious given the 20-year timeline for outliers costs to align with others. Another noted that OCA is proposing an iterative process that can be refined over time. The sector target is an important first step. Time is of the essence to address the impact of high healthcare costs, and they urged OCA to take immediate action. And then lastly, another comment in support noted that every day without action deepens the harm to working families, disproportionately impacting communities of color, low-income residents, and the uninsured. OCA's mandate requires urgency. And I'll pass it over to CJ for the next category.
Thank you, Vishal. So we'll talk about the methodology for identifying high-cost hospitals, starting with concerns that were raised. So with regard to the unit price measure, the unit price repeat outlier identification method can be modified to incorporate labor costs by applying the Medicare wage index to the calculation of unit price. Medicare's area wage index used to adjust hospital payments based on regional differences in hospitals' labor costs fails to appropriately adjust payments based on underlying regional differences in operating costs. The formula to calculate the commercial to Medicare payment to cost ratio, or PTCR, does not appropriately reflect the Medicare payment received by a hospital for a medical service in many cases. For example, structural differences between Medicare fee-for-service and Medicare Advantage capitation. OCA should modify the commercial to Medicare PTCR formula to use only Medicare fee-for-service in the denominator rather than grouping all Medicare types together to establish relative price. This would normalize the differences between Medicare fee-for-service and Medicare Advantage capitation. Separating Medicare Advantage capitation from Medicare fee-for-service would also serve to recognize the capitated reimbursement structure, lead to improved patient outcomes and reduced utilization. OCA's measure for identifying high-cost hospitals singles out hospitals whose commercial payments cover their costs better than Medicare. Next slide. Continuing with concerns about the methodology for identifying high-cost hospitals. The years 2018 to 2022 considered within the recommended methodology contain at least 3 years of financial impact from a global pandemic. The OCA board would be well served by deferring their methodology adoption for a few months until the 2023 data can be included. Relating to the discharge threshold, lower discharges mean less revenue to cover the fixed costs required even for a small hospital. The board should consider volume data such as average daily census or discharges to evaluate a hospital's inclusion on the list. Other comments, 9 of the 11 hospitals were below the 20%, were below the top 20% in all payer reimbursement per case mix adjusted discharge in 2022. Exempt safety net hospitals by increasing the commercial payer mix threshold to 20% or greater for hospitals to be included in the evaluation. Public healthcare systems report financials differently than private hospitals. For example, coding practices. Public health systems also provide more complex care. Measuring health system revenues at individual hospital levels does not work with system financing. The existing list of top hospital outliers is heavily focused on Northern California facilities, and it may exclude high-cost hospitals in other parts of the state, which should be included. Next slide is support comments for the methodology for identifying high-cost hospitals. All of the data proposed to be used by OCA for measuring very high-cost hospitals come from the financial data filed by hospitals with HCI. Each hospital submits this data. We operate on the assumption that each hospital stands by the data that they submitted. Beginning with high-cost outlier hospitals is aligned with affordability focus. High-cost hospitals are a major contributing factor to increasing healthcare costs in California. OCA's recommended methodology ensures hospitals on the list are truly high cost and outliers. The 11 highest cost hospitals are paid twice as much as the average California hospital. None of the 11 high-cost hospitals were among the financially distressed hospitals receiving loans from HCI. Employers and individual consumers pay these hospitals 4 to 8 times as much what Medicare pays as a proportion of costs. We dispute the hospital's contention that commercial payers must be charged more to make up for alleged shortfalls in payments from Medicare and Medi-Cal, as well as to help underwrite deficits in other parts of their systems. These hospitals should find ways to decrease inefficiencies and reduce waste if they're looking for additional funds. These hospitals are twice as expensive as the average California hospital. It makes policy sense that the cost growth target for these hospitals would be half as high as the statewide target, which applies to all hospitals as well as health plans, insurers, and physician organizations. Continuing comments related to identifying high-cost hospitals. Employer coverage and individual consumers pay these hospitals 4 to 5 times or even 7 to 8 times as much as what Medicare pays as a proportion of costs. When excessive amounts are paid for care at these hospitals, not only do members face staggering out-of-pocket bills, but they also forego money in wages and in wage increases. Monterey County, where the methodology identified 2 high-cost hospitals, has a rate of medical debt that is 6%, which is twice as high as California as a whole, which is at 3%. We support a 0.1% or even lower target for high-cost outlier hospitals. OCA should use its authority to mandate detailed public reporting from these hospitals to justify cost and impose non-compliance penalties. The methodology identifies the highest cost hospitals that lie at the heart of our current cost crisis. High-cost hospitals are being paid by employer coverage and individual consumers, many times what Medicare pays. And focusing on high-cost hospitals is logical and impactful due to their severe impact on premiums, out-of-pocket costs, and debt. With that, I'll hand it back over to Vishal.
Well, I'll be first going over concerns about the sector target methodology and values. Comments reflected that first, the target should consider or reflect inflation, demographic factors, trends in labor and technology costs, costs of new pharmaceuticals, policy changes, and upfront investments. Comments also noted that the methodology does not consider payer mix. OCA's commercial reimbursement measure disregards outpatient care, which is roughly 40% of care hospitals provide. High acuity specialty hospitals have longer stays, intensive monitoring, multidisciplinary teams that cause higher per patient costs. Financial estimates used in the methodology do not always match actuals, skewing performance data. Methodology doesn't account for unique challenges that rural hospitals face. Another comment noted that specialty care hospitals should not be treated the same in the methodology. Moving on to comments in support of the sector target methodology and values, they included supporting the proposed values and would prefer them to be lower, supporting the general direction of OCA's approach, but emphasizing the importance of a thoughtful, iterative process that can be refined over time. OCA's recommended methodology is transparent and relies on publicly available data reported by hospitals themselves. Slowing hospital cost growth will also slow health plan cost growth, since plans and insurers are paid administrative costs and profits as a percentage of claims paid to hospitals. And then lastly, another comment noted that it makes sense to focus on hospital costs and to make hospitals a sector when so much of commercial coverage, 40%, is spent on hospital care. And then turning it back over to CJ.
Next, we have concerns raised related to unintended impacts to access, quality, and workforce stability. The methodology does not address workforce training or graduate medical education, and in fact will reduce funding for these essential programs. Targets would result in cuts to investments in physician training programs that have already proven to be successful. Teaching hospitals have a higher operating costs and could shrink teaching programs to meet targets, negatively impacting workforce development. Hospitals will have a harder time recruiting, sustaining, adequate workforce. Hospitals will have to cut back on specialty services currently offered and cut service lines that will become cost prohibitive. Capped growth threatens lines of business that are not financially viable, such as labor and delivery. OCA's spending target framework will force premature operational, financial, and investment decisions impacting underserved communities. Cost-cutting measures would happen at the patient's expense. And despite the clear requirements in state law that various goals for California's healthcare system be protected and meaningfully considered in the setting of spending targets, OCA has performed no analysis or review of the potential consequences of the hospital sector proposal on access, quality, equity, or workforce stability. Next slide is support related to access, quality, and workforce stability. These comments include that consumers lack access today. Members should not be afraid to go to the hospital out of fear that they won't be able to pay their bill. Hospital care makes up the largest portion of premiums. Out-of-pocket costs are high for privately insured Californians with a hospital admission. Hospital costs are the single largest reason for medical debt. Half of Californian consumers report delaying and skipping care due to costs. Costs are so great that care becomes inaccessible, and we must simply suffer through illness and injury while trying to do our already difficult jobs.
Well, I'll be covering concerns about costs that are out of hospitals' control. So there are comments related to payer mix and reimbursement. The first of which was that commercial reimbursement is necessary for hospitals to be able to subsidize low Medi-Cal reimbursement. OCA risks penalizing hospitals for treating disproportionate shares of low-income Medi-Cal patients and elderly Medicare patients. Some patients have a more favorable payer mix. There was a comment related to safety net hospitals, physicians, clinics, and other providers caring for Medi-Cal enrollees, and how this absorbs how caring for Medi-Cal enrollees absorb the ongoing burden as the program continues to fall far short of reimbursing the cost of care. Under the last comment pertaining to payer mix and reimbursement, comments noted that OCA is not accounting for each hospital's entire payer mix to ensure all hospitals are equitably profiled, and state and federal supplemental program payments to hospitals. And then there were a series of comments related to geography, noting that higher physician costs in some geographic areas compared to others, and commercial reimbursement measures. The commercial reimbursement measure penalizes hospitals for operating in high-cost areas and paying workers accordingly. And now I'll move on to the next slide, which is still focused on concerns related to costs outside of hospitals' control. So there's several comments pertaining to inflation and tariffs. Tariffs may increase the cost of equipment, drugs, construction materials, electronics, and et cetera. Targets are 35% below inflation without considering potential tariffs. Some comment letters noted a Kaufman Hall report, which mentioned that Western states' hospital costs are currently growing at 6% for labor, 8% for supplies like personal protective equipment, and 10% for drugs. Targets do not cover inflationary increases for critical supplies, pharmaceuticals, seismic compliance, and state-mandated wage increases. And the last comment pertaining to inflation and tariffs noted that the spending target is well below rate of medical inflation and doesn't consider rising costs in staffing, medicine, and supplies. There's another comment that we bucketed under the category of other, which is nothing seen in OCA's methodology accounts for the COVID-19 pandemic in the analysis, and that the methodology fails to consider uncontrollable cost factors such as 2030 seismic retrofitting new minimum wage, as well as underfunding from Medicare and Medi-Cal. And then moving on to comments actually, I'm going to turn it back over to CJ.
So these are comments that were bucketed as other comments, specifically concerns. The potential end result of the sector target could be nearly $5 billion diverted from patient care by 2029, more than 10,000 jobs lost, and 83% of California's hospitals operating in the red. Basing the sector target solely on historical cost growth and household income is overly narrow and fails to account for multiple factors that impact healthcare spending. This spending target will significantly impact planned investment projects, and uncertainty at the federal level could result in cuts to eligibility and funding for Medicare and Medicaid. Next slide. These are other comments bucketed as support. Many hospitals have already provided examples of projects that they plan to begin to meet OCA's goals, and hospitals should find ways to decrease inefficiencies and reduce waste if they're looking for additional funds to cover shortfalls.
So I'll cover comments regarding concerns pertaining to consumer impact. The first noted that OCA's attempt to cut healthcare costs will cause a loss of healthcare access. Comments noted that a need to consider patients' perspectives and not implement the cap as proposed without further and more thorough investigation. OCA's actions could peel away resources and force changes that could lessen the quality of care, especially when research and healthcare seem to be under attack. And then moving on to comments in support with respect to consumer impact. There was a comment about the emotional and financial injustice of a $5,000 bill after 2 hours at the emergency room for shingles, and the need for a fair price for healthcare access. A comment noted that so many people live with health issues rather than seeking treatment. Healthcare should not be something to be afraid of, and it should not be something only the privileged and wealthy. A comment noted that the local but rural hospital generally charges double for the same services as the next community 45 minutes away, and that many residents do not have sick leave or reliable transportation and must bear outrageous costs. Another comment noted a 123% health plan increase, resulting in canceling the plan and changing longstanding family doctors. Another comment about veterans' benefits being gutted, the individual's elderly father being left without care for Parkinson's and not having the financial resources to make up the difference. Another comment noted that going to recommended annual doctor's appointments result in overwhelming cost of bills for doing the bare minimum. They question the ability to be an educator in this area and the impact on teacher turnover and students' quality of education. And lastly, a comment that every visit to the hospital results in a minimum payment of $100. Sometimes money is not available to pay bills and buy food. Last Christmas, there was no money to buy any presents, and United Way helped pay the rent since we had to keep paying for treatments. And then moving on to the next set of slides in support regarding consumer impact. There was a comment about the constant fear of losing limited financial resources due to the greed and neglect of the wealthy and powerful while foregoing dental care, treatment for osteoarthritis and other potentially debilitating health conditions. There was a comment that hospitals should stay within the Medicare allowable amounts when billing patients instead of gouging the people who are paying out of pocket. Excessive out-of-pocket expenses often result in medical bankruptcy and even homelessness. There was a comment that OCA must work for consumers and has the power to slow healthcare spending, promote high-value care for consumers, and help hold the health industry accountable. Do not let healthcare corporations water this power down. There was a comment in support for the board's proposal to further cap the price increases for local hospitals. Out-of-pocket costs used to be $0 a month, and they have increased to $1,500 a month. And that concludes the summary of public comments. Okay. So, we wanted to turn over to the board discussion history in terms of what the board has discussed today, and I'll turn it over to CJ.
Thank you. We can move to the next slide. So the following slides are a summary of sector target discussions held over the last 8 months regarding the definition of the hospital sector, as well as the development of a methodology and target values for high-cost hospitals. In August 2024, the Healthcare Affordability Board meeting was held in Monterey and focused on the high price of care in the region. OCA covered California, and researcher Christopher Whaley presented data highlighting healthcare costs in California and the Monterey region. The presentation included consideration of hospital price, quality, payer mix, and market concentration. The board heard from at least 100 members of the public about their experiences affording healthcare in the region. OCA and researcher Christopher Whaley presented the board with actions California could take to address hospital affordability concerns, as well as the tools OCA and the board have to address affordability specifically for hospitals. Next slide. So in October of 2024, the board discussed the statutory options to potentially address the high cost of care in Monterey County that various stakeholders highlighted in the August meeting. The board urged the office to provide options to address high-cost hospitals as quickly as possible through sector targets. The board asked the office to provide options that broaden the scope to include all hospitals in California, as well as options that narrowly focused on Monterey County. Next slide. In November, the board discussed potential attributes of facilities that may warrant special consideration when establishing a sector and sector targets for disproportionately high-cost hospitals. The attributes discussed included critical access, small psychiatric, children's, teaching and academic medical centers, specialty hospitals, state-run hospitals, county, and long-term stay. Board members broadly suggested that few of these attributes may warrant distinct consideration when defining a hospital sector and/or establishing sector targets for hospitals. The board requested to review hospital data by facility attributes and several financial metrics to inform defining a hospital sector. Next slide. In December of 2024, OCA and the board discussed hospital spending data and reviewed data showing the top 30 hospitals on 4 financial measures stratified by various hospital types and characteristics. The purpose of the discussion was to inform the board's deliberations related to defining a hospital sector and determine if any hospital types should be excluded from a potential hospital sector definition. Next slide. In December, the board suggested the following. There was not a clear pattern in the data to merit narrowly defining a subset of hospitals as a sector, creating multiple hospital sectors, nor preemptively excluding any hospital type from a hospital sector definition. The hospital landscape in California is complex, and that no one attribute or combination of attributes would merit exclusion from establishing lower target values, and all hospitals need to be evaluated. The nuances of hospitals should be considered when adjusting the target of a facility. Certain metrics were more informative than others when identifying high-cost hospitals that may merit a different target, specifically metrics that show how hospitals compare on commercial prices for services, and a review of hospital cost metrics by county. Additionally, OCA and the board discussed options the board had for defining sectors and establishing targets for performance year 2026. Several board members expressed support for defining all hospitals as a sector and adjusting the targets for select high-cost hospitals. Next slide. In January, the board voted to define all hospitals as a sector. This enables the board to adjust targets for facilities within the sector. OCA presented the board with an initial methodology to identify high-cost hospitals that may merit lower target values. This methodology includes a unit price and relative price measure. The methodology included a discharge threshold that would only qualify larger hospitals for a lower target. value and precluding approximately 60% of hospitals from an adjusted target. Many board members agreed that using multiple measures was an appropriate way to identify high-cost hospital outliers that merit a lower target value. And members and stakeholders suggested the discharge threshold was too high and that the discharge threshold be lowered or removed to include more hospitals in this determination. In February, OCA presented the board the office's recommended methodology for identifying high-cost hospitals and adjusting target values for these facilities. The methodology recommends identifying high-cost hospitals as those that are above the 85th percentile for 3 out of 5 years from 2018 to 2022 on 2 measures, the commercial inpatient NPR, net patient revenue, or NPR, per case mix adjusted discharge, or CMAD, and the commercial to Medicare payment to cost ratio. That also have a payer mix threshold of 5% and have comparable financial data in the annual disclosure reports. Continuing with the February 2025 board presentation, the methodology also recommends adjusting target values for facilities that meet the specified criteria using the cost relativity approach of dividing the identified high-cost hospitals' average commercial inpatient NPR per CMAD weighted by the number of inpatient discharges for the 5-year period from 2018 to 2022 by the outcome of all other comparable hospitals' average commercial inpatient NPR per CMAD weighted by the number of inpatient discharges for the 5-year period, dividing the identified high-cost hospitals' average commercial to Medicare payment to cost ratio weighted by the number of inpatient discharges by the outcome of the other comparable hospitals' average commercial Medicare payment to cost ratio weighted by the number of inpatient discharges for the 5-year period, averaging the outcomes and calculations from the calculations in steps 1 and 2, and then dividing the current statewide spending target by the outcome in step 3. This brings us to where we are today, and I'll hand it back over to Vishal.
So next, we'll share considerations in broader context for the proposed sector target. Under the status quo, as we mentioned in our proposed hospital sector target methodology and target values, these high-cost facilities would continue to grow no more than, or under the status quo, the high-cost facilities would continue to grow no more than the statewide spending target, but are doing so from a higher baseline level. Further limiting the rate of growth for these hospitals would bring the costs incurred by their consumers more in line with the broader hospital sector, thereby reducing historical inequities between high-cost facilities and more cost-efficient facilities. Also included is a reminder that a board follow-up item from February 2025, OCA presented data to show that it would take approximately 20 years for the average of the high-cost hospitals to come in line with hospitals at the 85th percentile of spending. A slower rate of spending growth promotes more equitable access to more affordable care for Californians. Also want to note that rooting the adjustment methodology in the statewide spending target underscores the principle of consumer affordability, as the statewide target is based on median household income growth, a key metric of consumer affordability. I also want to note that because the adjustment methodology is underpinned by the statewide target, this is part of a long process that began with the board's discussion of the statewide target. That discussion included various considerations across multiple board meetings, including statutory requirements, reviewing methodologies from other states, a review of economic and population-based indicators, historical and forecasted data, and adjustment factors identified in statute, all of which inform our current discussion on adjustments to the target. More detailed information about these earlier conversations is included in the spending target discussion history in the appendix. So I'll take us to our next slide about improving affordability while maintaining quality of care. In August of 2024, at a board meeting in Monterey, Dr. Christopher Whaley presented research showing that quality is not linked to price. This data demonstrated that hospital prices vary widely across the state, with over 5 times price variation that is not attributed to higher quality care or better clinical outcomes. Even though some hospitals identified as high cost in OCA's proposal have high quality ratings, CMS STAR quality data suggests the same quality ratings can be achieved at a lower cost. Next slide. So this slide shows a graph presented by Dr. Whaley in August 2024. It again shows that there's a 5 times variation in California hospital prices that is not linked to CMS quality stars. And I'll take us to our next slide. So this slide also shows a graph presented by Dr. Whaley from our August meeting using data from 2008 to 2018 from CMS Medicare cost reports and 2011 to 2018 quality scores from Medicare.gov. The authors of the paper referenced here investigated the association between hospital discharge prices and clinical quality improvement. They find no evidence that hospitals use higher prices to make investments in clinical quality. The figure shown here shows the change in clinical measures associated with the 2% price increase. Error bars show a 95% confidence interval. For all clinical measures, the 95% confidence interval includes a 0, meaning that there is no association between a change in the quality measure performance and change in price. And moving on to our next slide, higher public payer mix also does not explain high relative prices. The scatter plot shown here shows that there is no association between the relative price, the payment to cost ratio, and public payer mix. That is, as referenced by the slide title, a higher public payer mix does not explain high relative prices. And then going on to the next slide pertaining to workforce stability. The spending targets are intended to promote workforce stability by working in tandem with OCA's workforce stability standards, which are linked in this slide. These are a set of best practices for healthcare entities to implement. The purpose of the standards is to assist healthcare entities in implementing cost-reducing strategies that advance the stability of the healthcare workforce and without exacerbating existing healthcare workforce shortages. Adjusting the hospital sector target promotes the use of a more sustainable, cost-efficient employment, retention, and training practices in high-cost hospitals. For example, reducing costs associated with turnover and contract labor. And with that, wraps up staff presentation and turn it over to the chair.
Thank you very much. And both for, again, the many, many members of the public who engaged in sharing your comments with us. Just really, again, want to appreciate that. And again, appreciate staff for compiling those and summarizing those, and also reminding us of our journey in these last slides here. Turn it to the council for questions.
Yeah, thank you, Secretary. I also wanted to appreciate all the comment and in particular the very personal and detailed comment provided on all sides of this discussion. It was very worthwhile reading through. The one thing that stood out to me is that there seemed to be, reading between the lines, there's a lot of misunderstanding out there that a year on from when we set the system-wide targets, that providers aren't yet under 3.5 scaling down to 3% target, which means we have a lot of work to do to make that real, especially given that we're 4 months into the first year, non-enforceable year, but the target is in effect for this year. So it just reminded me that we have a lot of work to do out there on that subject.
Elizabeth.
Thank you, and thank you for this, I think, really important summary. One thing I wanted to add is that we are doing a similar analysis on commercial spending and are finding, just like everything reported here, higher quality is not correlated with higher prices. And in fact, the opposite is true. We're looking at quality using commercial data sets and employer data sets. And actually the reverse is true, that the higher quality outcomes tend to be associated with the lower cost facilities. So I think that that is just a really important premise as we talk about the impact. And then I think this is a question, but I mean, the overall impression is that from reading all of the comments is, those being paid want to preserve higher costs, those paying want to lower costs. And I guess I just was wondering if there were any examples that come to mind to the staff of folks who are, in the hospital or industry who were recommending strategies for affordability that we should be, focused on.
Throughout the comment letters we received from from hospitals, they did note that they applaud the goal of OCA and are aligned with our mission, and kind of the need to improve consumer affordability, but there weren't any specific strategies suggested.
I appreciate the discussion and the summary. A lot of statements were made in the comments. Was there an I mean, I get it. People are coming, I think, from the right place, whichever side they're from. Was there any fact checking done to be sure that the comments that were presented here today were actually accurate, or we're just taking at face value what people are saying is being correct?
We did not edit what they're saying. We reported it as they submitted it to us.
Okay, all right. So I guess, for example, one question actually, I think under the methodology, and I think people were trying to figure out how do we do this in a way that is more, I guess, workable and reasonable in their point of view, right? I see there's a lot of people saying we just need to do something. And then we have people saying, well, we need to think about the unintended consequences of decisions, right, that would have negative impacts, right? And so they're making suggestions, I think fairly concrete suggestions about approaches to look at it. So I don't think it was entirely just like, don't do anything. I do think that people were responding. So, one of the things is we were talking about it is that, in our board, we said, and I appreciate today's presentation about outpatient, right? Our discussion, mainly because when we started this journey, what was initially proposed, which was essentially to extend, basically take the inpatient and then say that also the outpatient's similar. We said, no, that doesn't work, right? But in the process of when you talk about the board journey, essentially we are only looking at the inpatient side of things and the growth, which certainly is a substantial part, but as was noted, 40%, I think, of hospital spending is related to outpatient. So, and I know we're going to eventually get to the target, but I guess the question is our target just going to be on the inpatient side since we don't know what's going on the outpatient side? Or as one of the comments was here, the OCA board will be well served by looking at, or do we plan to fold in the outpatient later? So I'm just trying to figure out, and that's come up, right, in the comments. How does the outpatient part, which I appreciate, again, I'm very grateful for the staff doing the hard work and presenting today. How does, basically are setting set standards based on inpatient. So is our target just going to be on inpatient, or is it going to be on the whole institution, which we have a 40% chunk out there that we have not evaluated whether now one can guess that perhaps the high cost in the inpatient will also be high cost in the outpatient. May be true. We don't know. Maybe, and some hospitals said, well, look, we're actually, trying to figure out how to distribute between two. And then we had the discussion about systems too, which we didn't really touch on here. So in fact, many of the members of the board talked about, and there were some hospitals who responded saying that, well, we're also supporting an ecosystem, right? I did talk a little earlier about social services, but even sort of the healthcare ecosystem. So how are we looking at that? And then someone did comment that, and there's no way around the pandemic, right? We're just going to have to incorporate that. But, will we get data for another year in a few months or not? So, but I guess the larger question is are we focusing just on inpatient for this target, and how are we incorporating the outpatient methodology you presented today that seems very promising into this as we're looking at the hospitals? We're going to reevaluate the hospitals now once we have the inpatient part, or how's that supposed to work?
So, staff should certainly respond or correct me if my response is incorrect. My understanding is that the direction we're trying to go is that the target would be evaluated on both inpatient and outpatient. We heard today the development of an outpatient measure. We didn't hear the sort of summary of how the outpatient and inpatient would be combined. I can imagine some pretty straightforward ways of doing that. The identification of the high-cost hospitals, what we've been presented to date, one of the measures uses both inpatient and outpatient, the commercial to Medicare payment to cost ratios. The other measure is focusing only on inpatient for the identification of the high-cost hospitals. But the target, whether the 3.5% target, or if we do have separate targets for high-cost hospitals, those targets would be, at least I would hope, and I think we're moving in the direction of evaluating those on both inpatient and outpatient. Vishal and CJ?
Yeah, that's correct.
Yeah. And the one other comment I'd like to make, and I appreciate all of the comments from the 328, is that the right number? The many comments that we received. One comment that I didn't see, and one concern that I would raise, not to keep us from moving forward, but just as we're kind of thinking about this moving forward, is that the hospital target is a target around price and not volume. And at least historically, I haven't looked for the last couple of years, but for much of the last decade, on the hospital side, the big sort of overall affordability, or part of the big overall affordability problem, has been rapid increases in volume and in outpatient volume. That still will be a problem for consumers moving forward, even if we, even with the 3.5% target, and even if we move forward and adopt lower targets for high-cost hospitals. And I'm not suggesting we shouldn't. I think we should. And we can talk in future years about the volume side. Certainly, the work on total healthcare expenditures does include both price and volume. As we've talked about in Maryland, they've looked at global budget approaches that deal with both price and volume. But just in part, this is also, I'm sure that the hospitals will not be at all mollified by this comment. I understand the concerns that have been raised. But even with what we're doing, it's still possible for hospital revenue to increase substantially through increases in volume, even if the prices are held to the target level.
Not seeing any other comments from council members, we will open up public comment. And again, this is related to the information that was just shared of the summary of the public comment received, as well as the last several months of activity and data shared through the meetings.
Thank you. We'll now open it up for public comment. As a reminder, please limit it to that agenda item and keep your comments to 2 minutes or less so we can hear from as many members of the public as possible. Noting for the record that we have about 120 attendees and a number of hands raised, and noticing in the room that we have a very long line of public commenters, encouraging everyone to do their best to keep it to 2 minutes. And I am going to do my best to keep us to 2 minutes each so we can move through this. This time I'm going to start with a virtual attendee, and then I will alternate between the two. Dina, your hand is raised. Please go ahead.
Hello, Chair Johnson, members of the board. My name is Dr. Dina Hubbard. I'm a board certified pediatrician and neonatologist, and I'm speaking on behalf of Cottage Health, a nonprofit system serving California's Central Coast through Santa Barbara Cottage Hospital and Goleta Valley Cottage Hospital, both designated as high-cost hospitals. Cottage Health is the safety net provider for our region, offering specialized services not only for adults, but for pediatric patients as well. Our hospital system is also a teaching hospital, sponsoring 90 residents across 4 ACGME accredited programs, including pediatrics, which began in 2022 and is graduating its first class in June this year. Cottage Children's Medical Center is a vital part of our hospital. It includes a pediatric ICU, a level 2 pediatric trauma center, and a 22-bed level 3 NICU, neonatal intensive care unit, that serves as a regional referral center and safety net provider. Nearly 50% of our NICU babies are covered by Medi-Cal. This is consistent across the nation in terms of Medicaid providing coverage for many NICU babies. It's also important to note that infants and children are not little adults. They require specialized care and expertise. While pediatric care payments are often less than the equivalent adult care payments, especially pediatric subspecialty care, I would argue pediatric patients provide the greatest return on investment. We focus on prevention, which is much more affordable than treating disease. Let me tell you about one recently, a baby born at 25 weeks that I just discharged. At birth, he weighed just 1 pound, 5.9 ounces. That's about the weight of a loaf of bread and only 12 inches long, the length of a standard school ruler, with the head the size of an orange. He could not breathe on his own, regulate his temperature, or survive without the constant hum of machines, tubes, and a highly specialized team by his side 24/7. His brain, lungs, and digestive system were still developing, as he was meant to still be inside the womb. He spent 105 days in our NICU and was discharged on his due date earlier this month at 7.5 pounds. He was cared for by a team of nurses, doctors, respiratory therapists,
2
pharmacists,
minutes.
dietitians, developmental care therapists, social workers, who could understand his unique needs and support his growth and development. We feel our current model is in jeopardy, being able to care for these patients in their home, near their family, and in their community. So we would ask that you please consider not doing these cuts so that you could it would greatly impact the care of vulnerable patients like this infant. So please remember pediatrics and our workforce. Thank you.
Thank you. Going to the podium.
Beth Capel for Health Access California. We appreciate the discussion today and also the many people lined up behind us and online. We again reiterate that we ask that you not delay. Consumers have faced these high costs for a very long time. You base the statewide target of 3.5%, which today applies to every hospital, every physician organization, and every health plan, on the ability of consumers to afford care. Already too many delay or skip care, even emergency room visits that they should get. 80% of California families live on less than $150,000 a year. Hospital care is a major source of medical debt. One of the facts you just heard in that summary is that medical debt is twice as common in Monterey as it is statewide. Lots of patients who are hospitalized or even who have an emergency room visit will hit the annual maximum out of pocket of almost $10,000 in a single day. How can a family who lives on 80,000 or 100,000, much less 60 or 70,000, afford $10,000 out of pocket for care they couldn't avoid? We will return later, but we want to emphasize again that a hospital that is twice as expensive as the average California hospital and that has no better quality is by definition a high-cost hospital and should have a lower target. Thank you.
Thank you. Looking virtually, Mark, go ahead. Mark, you're unmuted on our end. You might need to unmute on yours. The mute button's in the top right-hand corner of the screen. Moving to our next person at the podium, please go ahead. Mark, we'll come back to you.
Thank you for the opportunity to speak today. My name is Katie Leiden, and I'm a registered nurse for 21 years, proudly representing North Bay Health. I am currently the Vice President of Service Line, and we are a system deeply rooted in Solano County. We are passionately committed to serving our community, especially its most vulnerable members. We share the mission of OCA to ensure that healthcare in California is accessible, equitable, and sustainable for generations to come. And we applaud your efforts to rein in unsustainable cost growth. But a high-cost hospital is not only what we are. That lens is far too narrow. We are a high-performing maternity care center with a level 3 community NICU. We are a trauma center, a stroke receiving center, and a STEMI receiving center. We must also recognize that not all healthcare systems are positioned equally in this equation. At North Bay, 76% of our patients rely on either Medi-Cal or Medicare. We serve the largest share of Medi-Cal patients in Solano County, and we do so with pride because we believe that everyone deserves high-quality care, regardless of their means to pay. In 2022, 36% of our inpatient discharges were Medi-Cal patients. That's well above the 23% market average. And when it comes to emergency care, that gap is even greater. 55% of our emergency visits were from Medi-Cal patients, compared to just 37% across the market. We don't shy away from those numbers. They're a reflection of our mission to improve the well-being of our community by providing conveniently accessible, high-quality care. But they also point to the challenge. These pricing targets don't account for the real pressures that we face. Medi-Cal reimbursement rates remain low. Labor and supply costs are rising fast, and still we continue to show up. We expand our services. We're working to improve access and to care for the patients who have nowhere else to go.
2 minutes.
This methodology threatens to squeeze systems like ours, forcing reductions that could be devastating not only for our operations, but for the thousands of residents who depend on us. It will undercut the very programs and safety net services that make us who we are. We're not asking to be exempt from oversight. We're asking for a nuance, for flexibility, for a growth cap model that reflects our payer mix, our patient population, and our role as a community member.
Thank you. Looking virtually, Ellie, go ahead. Ellie, you're unmuted on our end. You might need to unmute on yours.
Thank you. I got excited and unmuted before you unmuted, so apologies. Ellie Mainshine on behalf of Sharp Healthcare in San Diego County. We appreciate the opportunity to speak once again before the OCA board in regards to the hospital-specific sector targets. We would flag, though, that while the discussion from the board, the question specifically from the board about alternatives or other ways of addressing some of these issues, we did note in our letter and in our comment letter changes to the methodology that would specifically address some of the concerns about avoiding penalizing high quality care that is efficiently provided by addressing the difference between fee-for-service reimbursement models and capitated models, which should be considered alternative payment models that are part of the enabling statute of OCA. So it would push back against the assertion that there has not been offerings of alternative ways of approaching this work to move the ball forward and achieve our shared goal.
Required to do what he needed to do. And at that other facility, who is great at cost containment, was not able to provide services to my severely disabled bipolar teenager. And they readily admit that they could not service me. So just because there's cost containment does not mean it's the right care. And as a consumer, I agree with healthcare affordability, but be careful about it just being a number and actually what is happening at those facilities. I was not able to get any substantial behavioral health care at a low-cost facility. And well, they don't have to. And so be very careful about how you're marginalizing those of us who are even already marginalized and stigmatized because of behavioral health. Thank you.
Thank you. Continuing at the podium.
I can now say good afternoon. Katie Bessler, Monterey County resident, educator, and labor leader. Allow me to begin and wish you all a happy Earth Day. I know that we're enclosed in this auditorium, but I have hope that we will have a moment to get outside and enjoy our Earth. Following OCA's meeting in August in Monterey County in August 2024, the research presented evidence that payer mix and healthcare labor costs in Monterey County are as comparable as those in other areas, and yet the two primary hospitals in Monterey County are consistently on the list of high-cost hospitals. I want to comment that Salinas Valley Health for over a year now has worked and listened to the workers of Monterey County and heard our stories. The others seem to ignore our concerns. We've known for years that Monterey County hospitals are driving up healthcare costs for commercial insurance payers. And finally, through OCA's work, our experience is validated. And the sector targets give us hope that the cost of healthcare can be slowed for our communities. We ask that the board not delay. Thank you.
Thank you. Continuing at the podium.
Members of the board, staff, Steve McDougall with CFT, a union of educators and classified professionals, president-elect of the Salinas Valley Federation of Teachers, because, you know, I'm a masochist, and president of MICSIG, a JPA that provides healthcare benefits throughout Monterey County and a little bit beyond to public sector employees, mostly education sector workers, also making me a masochist. In Monterey County, anyway. Listen. The threats of we're going to have to cut jobs, we're going to have to shutter facilities, or my favorite one, we'll see you in court, state of California. Okay. It's not unlike a kid on the playground who wants to keep misbehaving and communicates threats. In this case, the misbehavior is taking the treasure away from working class families. And when I say treasure, I don't mean stock portfolios, which are great right now, by the way, and of course, gold coins. I mean their emergency cash. Only to be built up and to lose it again. To get a raise and lose it to subsidize what's happening. And there's a reason why you're hearing from hospital providers and not anybody else pushing back on this. That's where the problem is. The data is clear. I'm not going to waste any more time other than saying the obvious. The delay will continue the economic crushing of working families throughout this state. And let's just think about where this has happened in other states, this exercise, like Rhode Island and Oregon. Did we shutter facilities there? I don't think so. Thank you.
Thank you. Continuing at the podium.
All right, good afternoon. My name is Karen Conant. I'm Vice President of Ambulatory Operations at Barton Health in South Lake Tahoe, California. Some of the services we provide to our community through our ambulatory division include primary care, cardiology, ENT, audiology, general surgery, GI, home health, hospice, neurology, OB-GYN, palliative care, pediatrics, plastic and reconstructive surgery, physiatry, psychiatry, rheumatology, orthopedics, urology, addiction medicine, pulmonary medicine, and urgent care. As stated in the last meeting, gotta calm down for a second. Many of these services are in a rural health center, which Barton is investing $6 million to expand in the next 1 year. Our most recent community health needs assessment has identified psychiatry and mental health services, as well as addiction medicine, as our community's greatest unmet needs. Unfortunately, these are also among the highest cost and lowest reimbursed services we offer in our clinics. Under the proposed spending targets initiated by OSHA, we'll be forced to scrutinize every service line. These proposed targets are simply too restrictive, especially in the face of rising operational costs, fixed expenses, and community needs for increase in access to services. If these spending targets are implemented, we may be forced to reduce or eliminate vital community services like mental health and addiction medicine, precisely the services our community needs most. As Dr. Pan advised earlier, our community health needs are being met by many organizations, including Barton Health. But without Barton Health's mental health and addiction medicine infrastructure, which includes psychiatrists, our community will suffer. Barton strongly supports a community investment metric in your methodology. Thank you. Thanks for your time.
Thank you. Continuing at the podium.
Good afternoon. My name is Clement Miller. I'm a nurse by training and the Chief Operating Officer at Salinas Valley Health. We're a 5-star district hospital and health system in the Salinas Valley of California. And I'm speaking to you on the behalf of our healthcare system, our employees, and the many community partners, some of which have reached out to you in public comment. I'm here to express our frustration and disappointment with OCA's decision to label Salinas Valley Health as a high-cost outlier, especially given our long-standing commitment to making healthcare more affordable and more accessible to everyone in our community. As an example, years ago, healthcare wasn't available for Medi-Cal members in our community, as in you could not go to a doctor's office to see a patient, but as to receive care. Many of our doctor's offices did not provide care to Medi-Cal patients. As we brought them into our Salinas Valley Health Clinic, we opened up that access, ensuring that all patients that were receiving care at our clinics could be seen. That included Medi-Cal patients in that population. We believe that the board has relied on flawed and ever-changing methodology, which fails to recognize the reality and complexity of our role as a safety net provider serving a diverse and predominantly government-insured population. As we've stated, 80% of our patient population is government insured, and reimbursement rates that with reimbursement rates that do not begin to cover the cost of the actual care we provide this segment of the population. Salinas Valley Health is among those who are deeply disturbed that the board is taking action as providers brace for potentially massive reductions in Medicaid eligibility and reimbursements. Adding sector target spending cuts creates a perfect storm that could destabilize care for the entire region with few alternatives. Providers across our region, including large federally qualified healthcare centers and independent physicians, rely on Salinas Valley Health to deliver critical specialty care to Medi-Cal patients and sent strong letters in support of our efforts. We are committed to the communities we serve, and we fear this action ignores the real life implications it could have on the vulnerable populations we serve. Thank you.
Thank you. Continuing at the podium.
Hello, my name is Chris Matthews. I'm the Assistant Vice President of Government Relations and Real Estate for North Bay Health in Solano County. I'd just like to make 3 brief points that I don't think have been touched on much before. North Bay, well in advance of the OCA initiative, made an ambitious goal of reducing its costs by $100 million, over 10% of our base costs several years ago. And that has taken several years, but is now bearing fruit. And so the last 2 years, North Bay is below the threshold that OCA has established. The second point is, in my role as real estate, I have to help source funding for new developments. If we're on the high cost provider list, our ability to get funding at lower interest costs will be severely impacted. Finally, I want to show through my own anecdotal experience of fighting cancer myself. 2 years ago, I was diagnosed with stage 4 prostate cancer. North Bay is the only healthcare provider to have a LINAC in our county. And in fact, we contract with many other larger systems. That LINAC saved my life. After 45 treatments, I'm now cancer-free from that. But my point is, we have to replace that LINAC. That will be in the range of $15 to $20 million. And we can't take it out of service as it is the only unit available in our county. We ask that you remove us from the list, and thank you for your consideration.
Thank you. Noting we still have no virtual hands raised. We have about 105 virtual attendees. Continuing at the podium.
Appreciate it. Good afternoon, Secretary Johnson and members of the OCA board. Marcus Watkins, Vice President, Chief Revenue Officer with Washington Health over in Fremont, California. A district hospital servicing Fremont, Newark, Union City, South Hayward, and Sunol. I know that we met with members of the OCA staff and really appreciate that, asked for some additional information. So once we got that information, probably a couple of weeks or a month ago, we tried or aimed to emulate the formula and what you put together. Haven't been able to do that successfully. You've heard that before though. But one thing that we did find is there was an anomaly in just how we report data to HCAI. We're a self-funded, self-insured employer. And so we pay for the insurance for all of our employees. But any services that have been provided at our medical facility, they're put into the commercial population as opposed to the other payer population. This is very significant because that means that if you're taking a formula that says commercial population, that's actually revenue, that it's a cost that we incur, and we pay for. So it's not really revenue that's coming from a commercial population. As such, by classifying the segment of discharges and revenue in the appropriate category for your exercise and evaluation, the CMAD changes, as well the commercial Medicare to commercial cost ratios change, which would actually move Washington Hospital from the high cost category. We would like the opportunity to meet with the staff again and go through the data and the anomalies of the data. And I know that we've reached out and I believe we'll be having that discussion in short order. We wholly believe that the analysis does not take into account the different levels of Medicare reimbursement, thank you, that hospitals receive. Our Medicare cost recovery rate is lower than other hospitals, and as a result is inflating our commercial to Medicare reimbursement payment to cost ratio. It's significant. What this illustrates, of course, is that the HCI data that OCA is relying on for its analysis is full of inconsistencies, especially in how hospitals categorically report their revenue. Understanding that HCI data was not intended to be used for this exercise, this brings us here today. We believe that OCA is an inaccurate, it's an inaccurate depiction and misaligned foundation on which to conclude and end. Thank you again. We urge the OCA board to further engage with us at Washington Health to understand our hospital dynamics, our history with relatively flat charges and commercial rates, our payer mix, overall, our community, and the negative outcome that could be imposed on the access to care in our community should the board not fully understand our unique financial characteristics and how we don't fit within the targets that are being proposed. I appreciate your time. Thank you.
Thank you. Continuing at the podium.
Chair Johnson, OCA board, thank you for having us here today. I'm Dr. Mike McDermott. I'm the new CEO at Montage Health, and I'm here to represent Community Hospital of the Monterey Peninsula, which is a core component of our integrated healthcare delivery system serving Monterey. I appreciate the opportunity to provide comments regarding OCA's consideration of sector-specific spending targets and the methodology for creating a high-cost hospitals list. It's your duty to ensure that all Californians have access to affordable, equitable, high-quality, and universal health care, but the Office of Healthcare Affordability continues to overlook critical facts. The February 2025 proposal to set reduced spending targets for hospitals labeled as high cost is fundamentally flawed. The proposal unfairly singles out a specific group of providers, relies on questionable methodologies and anomalous data, contradicts key aspects of state law, and threatens access to healthcare in communities throughout California. Most concerning to us is the catastrophic impacts these targets will have on patient care, likely decimating California's hospitals' abilities to sustain vital patient care services, including in Monterey County. Monterey County has 4 independent hospitals with a combined total of 678 licensed beds, offering 1 bed per 645 residents, placing us near the median range for California counties. Our hospitals operate independently and face robust competition. The largest expense for hospitals in Monterey County is personnel. Labor expenses account for 61% of our total costs, 7% higher than the state average. We serve a community where 49% of our residents are covered by Medi-Cal, a figure 10% higher than the state average. Additionally, we care for every patient regardless of their ability to pay, which further compounds the financial pressures we face. It's also crucial to understand that community hospital is not an isolated entity, but rather the core of an integrated delivery system that supports essential healthcare services in our region. Over the past decade, we have faced a collapse in primary care practices in Monterey County. In response, we have formed Montage Medical Group, which now employs more than 100 clinicians, primary care and including specialists in neurology, urology, infectious
2:30.
disease, vascular surgery, and critical care. To sustain these vital services, Montage Health absorbs an annual loss of more than $35 million. In addition, we subsidize millions of dollars annually to maintain Ohana, the county's only transformative mental health campus and programming for children, adolescents, and parents.
3
I
minutes.
urge OCA to withdraw this proposal until these issues are thoroughly addressed and a more balanced consideration of sector targets is conducted under all relevant statutory factors. It's not too late to change direction and correct the process that will determine the future for millions of Californians. Thank you.
Thank you. Back to the podium.
Good afternoon. My name is Christine Seawright, and I'm here to represent North Bay Health. And in particular, I am going to be reviewing the remarks by our CEO, Mark Bell, who was unable to join by our webinar. I think one of the most important things we want to talk about is really healthcare containing cost, in particular the services preventative and primary care, and how those are really the drivers of lowering healthcare costs. There are I'm really providing those options throughout the community. There's a staggering need for additional primary care services throughout California, but particularly in the North Bay. About 11.4 Californians, 1/4 of our state's population, live in a federally designated primary care health professional shortage area, or healthcare desert. And 2/3 of them are Black, Latino, Latinx, or American Indian, highlighting the disproportionate impact of workforce shortages on California's communities of color. North Bay has pledged to invest $250 million over the next 6 years to increase the volume of much-needed primary and urgent care services. This investment would serve more than 200,000 patients annually. These preventative care initiatives will drive down long-term health care costs and help fulfill severely unmet needs in Solano County. North Bay is bringing new clinics to communities like Rio Vista that have been without a neighborhood clinic for over 13 years. North Bay would bring primary care clinics within a 15-minute drive of every patient and specialty care within a 30-minute drive, addressing a significant unmet need. The health care cap may significantly limit our ability to provide these services, and it is crucial that we provide these services to our underserved communities. Thank you very much.
Thank you. Continuing at the podium.
Good afternoon, Oak Board and staff. I'm Dr. Clint Purvance, President and CEO of the Barton Healthcare System. speaking to you again. Last spoke with you in February at your February board meeting. Thank you for the opportunity to have public comment. In February, 3 days prior to your board meeting, Barton had learned, not from OCA, unfortunately, but from an outside entity, that we were included on your list of high-cost hospitals. I just wanted to share with you briefly our journey over the last couple of months with your staff, and also just in looking at all the public comment and the concerns around some of the methodologies and challenges we face. While Barton may not have been given the opportunity originally to meet with OCA staff prior to that list coming out, I do want to thank the executive or the deputy director and assistant deputy director who spent time personally with us numerous times. And I do appreciate that, very grateful for that staff engagement. Since we've met with the OCA staff, we did recognize that Barton had submitted data incorrectly to HCI. I think you've heard that testimony before. It's something we rely on a third-party vendor to work through. And in that submission, we had incorrectly characterized our payer sources, which led to Barton's inclusion on this list of high-cost hospitals. This data was corrected and sent to the OCA staff. In fact, Toyana and Associates, our third-party vendor, is working to correct that data over the past 5 years as well with HCI. And under the methodologies today, based on the data that we've provided to staff, Barton will no longer be included in the high-cost hospital list. However, in the haste to publicly share data through your meetings, they are public meetings, which had not been validated. Barton had not been afforded the opportunity to take a look at that data. Barton's reputation has been harmed by media outlets. Specifically, media outlets in the Monterey area picked up the list off your website, and while they declared that one of the Monterey County hospitals was the second most high-cost hospital in the state of California, Barton was the first. This was also picked up nationally by other media outlets, and today I have inquiries in our PR department asking what's Barton's response to being the most expensive hospital in the country. This false narrative has created unnecessary fear and anxiety amongst patients and community members in Lake Tahoe, and it erodes the trust that we try and strive very hard to create for those who seek our care. Barton respectfully requests that after OCA carefully consider and reviews these concerns, that a simple media statement be made that corrects the inaccuracies. What is Barton known for? It's not the highest cost hospital in California. In fact, Barton is consistently in the top quartile, if not the top decile, of patient experience in the nation. We strive to deliver consistently exceptional care to our patients and community. We have some of the best quality and safety metrics in the state of California. For the last 5 years, Barton is listed on Newsweek's World's Best Hospital list and is a U.S. News and World Report Best Long-Term Care Hospital, earning a CMS 5-star rating. And recently, we were also listed #2 on Forbes' Best Small Business Employers in America. Barton is a small rural healthcare provider. However, we are recognized on many levels as leaders in the healthcare industry and the care that we deliver every day. We live our mission to deliver safe, high-quality care, and we strive to be consistently exceptional in that care, known as the community health leader, and chosen for quality and compassion that we deliver every day. I thank you for your time and consideration.
Thank you. Noting we still have no virtual hands raised. We have about 100 virtual attendees going back to the podium.
Ivana Krajinovic with UnitedCare Health, taking care of hospitality workers across the state, and we've spoken mostly about Monterey County. I want to thank the board for your diligent work over the last 2.5 years. It's too bad that many of the speakers here today haven't watched you methodically go over all of the arguments that have been made and to deal with labor costs and payer mix. And I think you're really well positioned to make a decision. And I feel honored to have been part of that process as well. I wanted to provide an example to something that Dr. Pan talked about earlier about the outpatient costs. We recently paid $16,000 for an infusion of Prolia. So this is not a cancer drug. I've talked before about how we've been paying 8 times Medicare for chemotherapy at CHOMP in Monterey. This is not a chemotherapy drug. This is drug for gastric issues. And this was a whopping 10 times what Medicare would have paid. This is an infusion that's administered normally every 6 months, so we can expect to pay $32,000 for this drug this year. There's a local independent practice that would do this infusion for 1.5 times Medicare of about $2,500. So an extra $27,000 that we're paying. That's money that could go to workers, low-wage workers, and wages. Moreover, this participant also would not have huge out-of-pocket costs. They are responsible for 20% of the bill. That means that they will pay $6,400 this year for this medication, right? I don't know what all the talk about rushing is. This needs to be addressed now. I also just wanted to share some new data from NASHP that compares drug costs with drug charges, and you can see the spread growing over time. I've given you screenshots from Salinas Valley, Chomp, and Stanford. Chomp and Stanford last year charged 8 times what it costs them to buy drugs, where Salinas Valley is at a whopping 14 times the charges. Stanford spent about $783 million on drugs and charged an astonishing $6 billion with a B for those drugs. Time to act is now. Thank you very much.
Thank you. Looking online, we have about 96 virtual attendees, seeing no hands raised at this time. Looking to the podium and seeing no one at the podium. That concludes public comment on this item.
Just want to thank the members of the public again for those in person and those virtually for participating and not only sharing and bringing to life some of those letters that were submitted, but also in those that were also sharing their personal stories. Really appreciate you doing that with us this afternoon. We will take all of these things into consideration as we head into our next agenda item. But before that, we will take a 30-minute break and we'll resume, let's call it 1:30. Thank you. Welcome back. We are going to resume the Healthcare Affordability Board meeting, and I will ask for the roll.
Dr. Sandra Hernandez. Secretary Kim Johnson.
Here.
Richard Cronick.
Here.
Ian Lewis.
Here.
Elizabeth Mitchell.
Here.
Dr. Richard Pan.
Present.
Don Moltz. All right. 5 present, 2 absent.
Thank you. We are going to now move back to item 4A on the agenda, which is a vote to establish a hospital sector target on or before June 1. The board may establish a target value. And again, we'll note that if the board chooses not to vote in this month, as was previously stated, this action item will be placed on the May agenda. So we will now turn it over to Vishal Lakhani to present.
All right, good afternoon. My name is CJ Howard, the Assistant Deputy Director over the Healthcare Spending Targets Branch. Prior to potentially taking action on this item, we have some summary statistics and alternative options for the board's consideration. So we can move to the next slide. This slide shows statistics for the high-cost hospitals that were identified in OCA's February recommendation. We provide this for the board's awareness and context as we're going through this deliberative process and discussion this afternoon. A few key points. We provide the licensed bed counts, staffed bed counts, annual inpatient discharges, and discharge percentiles, as we'll discuss below a potential discharge threshold for inclusion as a high-cost hospital. Goleta is at the lower end of the discharge percentile at 23rd percentile, and Barton at 26th, respectively. Stanford is at the higher end of the 97th percentile of discharges. These metrics provide some context and scope and scale for the facility. We also provide the values across several financial metrics for the 11 hospitals from OCA's recommendation. Margin, commercial NPR per CMAD, the commercial to Medicare payment to cost ratio, and the public payer mix percentage for each facility. Where the facility with the highest public payer mix is Doctors Medical Center of Modesto at 82% or 18% commercial pay. That's another way to think about that. On the next slide, The slide shows characteristics of high-cost hospitals. It has columns for whether each hospital is a critical access, small, children's, teaching, specialty, psychiatric, state-owned, public, or long stay. One hospital is indicated as small, in that being defined as having fewer than 100 beds, licensed beds, and 2 are identified as teaching hospitals. Those are Santa Barbara Cottage and Stanford. And again, we're just providing these for the board's awareness and as we're going through these discussions. Can move on to the next slide to discuss some potential adjustments to OCA's February recommendation. Next slide. So the board has decision-making authority to decide whether to apply lower targets and determine the target adjustment methodology and target values. Some potential adjustments that staff are presenting today for identifying high-cost hospitals include a discharge threshold that would remove smaller hospitals. In December of 2024, the office presented an option to only include hospitals with above average discharges. OCA's February 2025 recommendation removed a discharge threshold, though the board could consider removing hospitals below a specified threshold value, for example, the 30th percentile. We also discuss the potential of removing hospitals that demonstrate a decreasing trend in the unit and/or relative price metrics. I'll discuss these in more detail in the following slides. So the first one on the next slide is establishing a discharge threshold. In January of 2025, OCA presented a discharge threshold. The threshold was set to exclude hospitals that were below the statewide average number of discharges. This average is approximately equal to the 60th percentile, or would have excluded 60% of facilities. At the 60th percentile, this would have removed Goleta, Barton, and Marshall from the high-cost outlier list. The board and other advocates opposed removing 60% of hospitals from being considered for a reduced target. A threshold was supported initially by input from the advisory committee to focus efforts on larger hospitals that are bigger drivers of cost and market dynamics. So both the advisory committee as well as several hospitals suggested that hospital size should play a role in determining whether they should be subject to a reduced target. So one potential option that we are presenting is to impose a discharge threshold at the 30th percentile, which would remove Goleta and Barton from the high-cost hospital outlier list. If you move to the next slide. The table on this slide shows how different discharge thresholds correspond to different metrics of hospital size among 366 comparable hospitals in 2022. Note that at the 30th percentile, the average number of staffed beds is 39, the average daily census is 36, and above the 50th percentile, the average number of staffed beds is 221, and the average daily census is 211. We're not suggesting to establish thresholds based on the number of licensed beds or staffed beds or average daily census, but merely to provide more context for the number of annual discharges and percentile and what that may suggest or show about a facility's size and scale. So another option for the board's consideration or potential modification is related to considering recent trend. So a board member asked what happens when we see an improving trend in more recent years, or how the board should address hospitals that may show an improving trend in the more recent years. The board could remove hospitals that demonstrate an improving trend in the more recent years from the high-cost hospitals list. So one way to implement this is the board could exclude high-cost hospitals that have a decreasing values for 2 consecutive years on the commercial inpatient NPR per CMAD and the commercial to Medicare payment to cost ratios, which results in the hospital falling below the 85th percentile in the most recent reporting year. So the next 2 slides will show the impact of implementing either or both of these potential adjustments. So if we were to go forward with, let's say, the 30th percentile, a discharge threshold set at equal to the 30th percentile, the hospitals highlighted in, call it salmon, would be Barton and Goleta. would be removed from the high cost hospital outlier list on the commercial NPR, on the commercial NPR per CMAD. And then similarly, Marshall and North Bay would be removed for their improving trend on this metric. Go to the next slide. Same story with the discharge threshold. Barton and Goleta would be removed. And then also Marshall and North Bay would be removed based off of their improving trend on the Medicare, commercial to Medicare payment to cost ratio metric, and yielding in the most recent year being under the 85th percentile. So with that, I will pass it over to Vishal to walk through a couple of draft motions for the board's consideration.
So we'll look at some draft motions that OCA has put together for the board to consider. Per the when we get to a point for board discussion, the chair will facilitate the discussion pertaining to whether other board members would like to propose a different motion. And we'll work with that board member to draft slides for review in this meeting. So taking us to the next slide for draft motion 1 to define high cost hospitals and adjust target values. This first motion would implement the office's recommendation that it published in February. The key components of the motion includes 1, set the hospital sector spending target equal to the statewide spending target. 2, identify the 11 hospitals listed as high cost hospitals as they are above the 85th percentile for 3 out of 5 years from 2018 to 2022 on commercial inpatient NPR per CMAD and commercial to Medicare payment to cost ratio or PTCR that have a payer mix threshold of 5% and defined as having comparable financial data in the HCI hospital annual financial disclosure reports. Notably, this motion does not include a discharge threshold. The third component is to adjust the spending target value for high-cost hospitals by dividing the statewide spending target by the average of the high-cost facilities' cost relativity values on inpatient NPR per CMAD and commercial to Medicare payment to cost ratio, which equates to 1.8% in 2026, 1.7% in 2027, and 2028, and 1.6% in 2029. Next slide. So here we see draft motion 1 would produce the specified target values for high cost hospitals for 2026 to 2029. And then going on to the next slide, this slide would show the 11 high cost hospitals with their respective target values for the years 2026 to 2029. I want to note that all other hospitals in the sector and healthcare entities are subject to the statewide spending target. Next slide. So this takes us to motion 2. First, the motion would entail setting the hospital sector spending target equal to the statewide spending target. Then the second step would be to identify, or the second component of the motion is to identify the 11, or the, excuse me, 9 hospitals listed as high cost hospitals as they are above the 85th percentile for 3 out of 5 years from 2018 to 2022 on commercial inpatient NPR per CMAD and commercial to Medicare payment to cost ratio. Are above the 30th percentile in annual discharges, have a payer mix threshold of 5%. And this is why Goleta excuse me, and have comparable financial data in the hospital annual disclosure reports. The third element of the motion would implement the improving trend modification that we covered earlier. So it would exclude high-cost hospitals that have decreasing values for 2 consecutive years on the commercial inpatient NPR per CMAD and commercial to Medicare payment to cost ratio measures, which results in the hospital falling below the 85th percentile in 2022. This would effectively remove Marshall Medical Center and North Bay Medical Center. And then lastly, the fourth element of the motion is to adjust the spending target value for high-cost hospitals by dividing the statewide spending target by the average of the high-cost facilities' cost relativity values on commercial inpatient NPR per CMAD and commercial to Medicare payment to cost ratio, which results in the same values as motion one, which is 1.8% in 2026, 1.7% in 2027 and 2028, and 1.6% in 2029. So I'll take us to the next slide. So here we see draft motion 2, which would produce the specified target values for high-cost hospitals for 2026 to 2029. And then going on to the next slide, we see the target values for the updated list of 7 high-cost hospitals and annual targets for 2026 to 2029 if the board pursues the second draft motion. And like motion 1, I want to note that all other hospitals in the sector and healthcare entities are subject to the statewide spending target. I'll now hand it back over to the chair to facilitate board discussion.
Thank you very much. And I just want to maybe start the discussion on this item in recognition of what's come up a few different times this afternoon and previous to this, which is the time of great uncertainty that we're living in, particularly with the volatility of the economy and proposed threats to healthcare coverage at the federal level. So I want to acknowledge that. I also want to say that in some ways that makes it even more critical for this board to uphold our promise of improving affordability for Californians. So I want to appreciate too that as we are engaging in this, we talked a lot about kind of how we got here, but also the process components, and both the OCA staff and the board will focus on enforcement of spending targets, where we'll address, among other things, reasonable factors for exceeding the spending target. And of course, we've also heard from entities related to the items that are outside the control of healthcare entities, like high costs of certain specialty drugs. So I just think that public process will help provide clarity to the regulated entities on what to expect for the 2026 performance year, which is the first enforceable target year, correct? 2026. I also just want to confirm that, confirm my understanding of the statute for this work, directing the board to periodically update spending targets so that new information is used to inform any potential changes that we may take action on. Is that correct?
That's right, Chair Johnson.
So, I would hope that as we're considering these motions, and again, thank the staff for putting some items here reflective of our conversations in the past going together, that we have the opportunity either through front-end adjustments through the periodic updates that we just referenced to the target, or evaluation of the factors during enforcement, that we have the ability in some statutory options to respond to any extraordinary circumstances that may occur that are outside of anyone's entity control within California. So I want to appreciate that. I, based on all of those things and what you have put in front of us in our conversation and considerations to date, would like to move to advance motion 2 as laid out on this slide. And I will call to see if there's a second for that motion.
Second.
Okay, thank you. And then let's go to discussion from the board. Okay, we'll go to Dr. Pan and then to Elizabeth.
Appreciate the presentation. I actually have several questions. So first of all, in terms of the criteria, which of course we have discussed on several occasions, but one of the things that I'm not sure is entirely clear is, so moving forward, so what happens, we've taken a set of data for a point in time. So we look back 5 years and ran these numbers. And I note that the motion actually specifically calls out specific institutions. It's not the standard, it's actually institutions that get called out. So for example, are we going to look at so next year, are we going to run the same standards against the database and see not only the existing hospitals, but, and admittedly, if you look at those hospitals, aside from the two exceptions, they've been essentially exceeded this for the last 5 years, actually. But if they saw the light and figured out a way and they suddenly were 2 years below, so not the two we're talking about who have been 2 years below for the last two, but going forward to next 2 years and they're both below, do they come off the list? So do people come off the list because they've shown that they are able to get below? And then the other question is that can people get on the list? If there were 3 years, so you weren't before, but for the next 3 years, and we run it, and it's like, oh, you keep showing up now. Do you get on the list as well? So are we running this thing each year and seeing who's on there each year, and then eventually deciding whether people should be coming on or off the list?
Thanks, Dr. Pan. So in motion 2, we do have that improving trend where it ultimately, the 2 years of improving trend ultimately results in them.
So that's looking forward as well. So it's not just for this year, because you're like, the improving trend was it just for, oh, well, we have 2 hospitals that had improving for the last 2 years. But what about moving forward? Because if you're improving, suppose you're one of the other hospitals and the next 2 years you're below, do you come off?
Yeah, I'll take that in a few parts. So the first question, or one of the questions was about kind of is OCA and the board going to kind of rerun the analysis every year. So that'll be up to the board on kind of what cadence they want to do this on. It could be an annual process, or it could be every 2 years. It's really up to the board. And then the other question about like getting on and off. So it depends on the cadence. If we want to revisit this next year, then potentially new hospitals could be added to the list. And then since we're looking back 5 years, we're going to have an additional year of 2023 data. So then if we see an improving trend, which in this motion, we're recommending 2 years of improvement that results in you being under the 85th, then it could result in that hospital coming off the list.
Okay, so I would, we can discuss whether we think, we've had discussion about the threshold, but I would think that we should probably look at it annually, right? And then we can, and also that gives a signal to the hospitals, you're heading this direction because you got to do 2 years in a row. And one of the other things that's related, and I do have to ask this as well. So a couple of the hospitals have testified. I think Barton said, oh, well, and admittedly, I mean, people say, oh, well, they certified this number's accurate, et cetera. But realistically, what happened is this data was not being used in this way. So the way people interpreted things, if it was not exactly the way we're looking at it now, it's not that it's quote inaccurate. It's that what happens, it probably didn't have consequence, and they kind of like, well, it's kind of gray, so we're not going to go and fight it or whatever else. But now it's making a real difference. So I think one of the issues is also going to be data quality. All right. And the fact that we're now using the data for this purpose means that people are going to seek greater clarity as to exactly what their submission is, whether it's vendors or the hospitals themselves, or they happen to pay. You're a smaller hospital, you're probably paying a vendor to do this work, because instead of your own staff. And then I think that's going to be important because I think the quality of the data, some people might consider, at least people awareness data is going to be better, right? Some people may argue they're going to be a little bit more manipulative, but I think that, but I guess one of the things that did come up, which actually disturbed me a bit, is the Hospital Association also testified that they can't seem to rerun the numbers and get the same results. So can you comment on that? Because I mean, that's not the criteria, but that's the strength of the data and the transparency of the data that we're using, the decisions we're using to come up with these. So the argument isn't that, they're asking us to just not do this all, not, at least not right now. But even if we did it now, they'd raise the issue of, is the number actually accurate or not? That they can't duplicate it. So can you speak to that?
Yes, in our meeting with the California Hospital Association, the staff said that they have been working on replicating the numbers. They do have SMEs on their staff that work with the HCI financial data. They said that they came pretty close on the payment to cost ratio. And subsequently, they requested the full data set that OCA has been using. So we provided that. We provided the documentation in terms of step-by-step instructions and the programming code that we used. And we provided that to them on April 9th.
Okay, and obviously they're not, they're in the audience, but I'm not sure whether I can ask them the question, like, did they try running it to get the same results? I mean, they testified they weren't able to duplicate it. So that's a little concerning. I think, we should need to explore that. Is it doing it wrong, or they don't have enough information, or is their data set different than the one that we're looking at? And then in terms of the discharge threshold, and I think, I was one of the ones who point out that discharge threshold seemed to be really too high when you're excluding 60%. I guess one of the questions to me is that in terms of trying to figure out how to set that threshold, you sort of threw out 30%, provided some data there, but it's that the purpose of the threshold was to try to say that at a certain point, the number gets too small where you start having a lot of variation, right? I believe that was the rationale for saying the threshold. Have we done an analysis, say at what threshold number is that it's probably not a cliff, but that variation starts getting too wide. So it wouldn't be a percentile, it would be a number, right? Like you have X number of discharges, or at least between this range of discharges, the variation starts getting wider. Now, admittedly, different hospitals, different areas, and they have different, so maybe it's not entirely consistent from hospital to hospital, but there's probably an error, a range, and do we know what that is? So I appreciate you threw out 30 now, but I still haven't seen the data to show, hey, this is the place where, yes, the number becomes kind of so variable or inaccurate that we don't want to use it. So those hospitals, it's hard to get good, to do good prediction because the variation starts getting too wide.
Yeah, we have, in terms of small hospitals, they are going to be more volatile in terms of, the number of patients they serve. We haven't done kind of a, where's the cutoff where it becomes less reliable, but kind of as an initial discharge threshold, this is kind of what we laid out as recommendations, but I'd probably want to turn to Board Member Kronik if he has any thoughts on this.
Yeah, I don't have an answer to your question, Dr. Pan. I do think it's a combination that in thinking about what might a good threshold be, combination both of your question of what's the variability like, and also when is a hospital so small as to kind of, it still affects affordability, but if it's so small, why bother? Kind of. And I'm not, I don't have a magic answer to that either, but a hospital with, an average daily census of 36 beds, 36 patients is a pretty small hospital. And you ask a good question about kind of how much variability is there at that size relative to a hospital with, say, average daily census of 60. I'm sure there's more variability. I don't have a quantitative answer to kind of how much more variability, but a combination of variability and it's pretty small to me would lead me to support the 30% as a kind of reasonable threshold.
Okay, so I appreciate the 30 percentile, but it'd be good to have that analysis to the degree that to help us figure out, like, is the 30% or X number of discharges is the place where you start having. I realize it's not going to be a cliff; it's going to be a trend. So at some point we say, okay, that variation is just getting too big, and so that's where we'll draw the cutoff. And it's perhaps not a percentile; it's probably a number of discharges. Right. So because depending on what you have a bunch of little hospitals, they're all going to be right. What's the percentile? You have a bunch of, a few big hospitals. So, it's that kind of thing. So depending on what the distribution, but like Southern California has a lot more smaller hospitals, right? Northern California tends to be bigger hospitals. So that's part of the challenge about just using a percentile. So you exclude a lot more hospitals from a certain region than another region just because of the nature of the average size hospitals in these different regions and how the hospital sector evolved. So, and then the other thing wanted to, let's see, touch on was basically, so we have the discharge threshold. We talked about the sort of the trend line. So I did pose the question, but I didn't actually get an answer to it last time. Although Dr. Novick, you acknowledged my question. So the outpatient, which you presented, what is the future of that? How's that going to be put together and when? So that I did pose that question, and I don't think I actually got an answer to that.
Yeah, so those outpatient weights that I presented on earlier, they're currently being loaded into they are loaded into the HPD now, so we could perform, we're calculating those kind of weighted averages for each facility now. We're going to convene the work group to get additional feedback. But by the end of the year is our goal to have, production data on the outpatient measurement. And then in terms of kind of reporting on the performance year, so it would kind of, it'd be based on the same cadence that HCI hospital financial data is released. So as we're just getting 2023, it should be kind of coming out in the next quarter or so. So there's always going to be a lag in terms of when the data is going to be available. But essentially we would take that inpatient NPR per CMAD and then we could add the outpatient NPR per adjusted visit. And then those two could be combined to get a combined measure. But it's a little more meaningful to kind of look at them separately so you can kind of see what's going on in the inpatient side and what's going on in the outpatient side.
So, so what I would suggest as you bring this up is that not necessarily saying, although I'm sure some people in the audience would hope I'd say this, is that we necessarily belay this, but I would say that then next year we should relook at this, given our new capacity to look at the outpatient and think right. And so some people may fall in or out because of that as well. So again, I just want to put a pin on that what we're, whatever we decide today, if we do this, that next year, we're going to use something a little different than the current proposed methodology, because hopefully we would have developed this other tool that you presented earlier this meeting, and we're putting those together. And so we will revisit next year with this new information and also some proposals to how to, you want to look at separate, but also how you put it together, and then how would we then rank the hospitals in a way to hopefully is more reflective of both their inpatient and outpatient. I get the Medicare thing sort of does both, but as well, right?
Yeah, we agree with that. The identification of high cost hospitals, that it was based on those two measures. We could add measures over time. We definitely want to add the outpatient component. And then for the actual spending measurement, we've described it as provisional intentionally because we do want to enhance it over time.
Yeah, and obviously there's an ongoing discussion as you develop it over the year to hopefully by a year from this month, hopefully we'll be in a position to figure out how we're applying this, right? So,
yes.
Okay. All right. Well, I certainly have more questions, but I'm going to stop there. And thank you.
Thank you. Elizabeth.
Thank you, Madam Chair. I am supportive of motion 2, and I want to really just emphasize how important I think it is that the ratio of commercial to Medicare is an area of focus, because I think that's where the affordability crisis is most acute in the commercial market. And we have heard so many dire warnings that they're going to cost shift even more. And I think if we show progress that they're actually not increasing commercial costs, I just think that weighs very heavily, at least for me. So I appreciate that element of this. A friendly amendment, perhaps, and I don't know the protocol here, is because we're hearing so much about challenges with data and maybe the numbers aren't right. I think to be eligible for this, I think hospitals should be 100% compliant with federal transparency requirements. I mean, it's already a requirement. We just don't have good compliance. It's variable. And so I think the more transparent information we have on costs, the easier it will be to track progress. So I think that would be an in addition. Mhm.
Thank you, Secretary, and thank you for contextualizing this and the urgency to take action. For me, that is an overriding consideration. As you all know, we've spent 2 years listening to testimony about the devastation in communities as a result of costs and hospital costs especially, and thanks especially to the Monterey community that has organized itself to take this on and focus on us on it. That said, I do want to state my concern that the modesty of what we're doing here, especially with option 2 or motion 2. I mean, we're contemplating taking fewer than a dozen of the 430 odd hospitals in the state and putting them on a 20-year track, not to come into line with the rest of the state, but to go from the egregious outlier category to the simply an outlier category. And I don't think that that is moving fast enough, but we have to start somewhere. A lot of the public comment I've heard, the critical public comment I've heard today, I think would be addressed by, if we were in a position to set a fair price for commercial claims, but that's not the mandate the legislature has given us. And so we're in this experimental phase with target setting. I do want to say, if this is as far as we can go today, I guess it is what it is, and I take solace in the notion that we can come back and revisit this at a future time. On the outlier question, the discharge threshold question, I mean, we have to make our best judgment what a threshold is. For cost, we've said it's the 15th percentile of cost. And here we are for discharges saying it's the 30th percentile. And my thinking on this would be very different if we were looking at the 30th percentile of costs as well as the 30th percentile of discharges. Likewise for trend, I think, we have heard, we haven't verified that there are data problems, but there are big reductions in trend, at least for one of the facilities in question. I would think very differently about a hospital who, for data reasons, or better yet, for changing behavior, went from the 87th percentile down to the 60th percentile in the space of a year, as compared to a facility just dropping from 86 to 84. And I'd be very concerned to see our list winnowed down from what we're talking 7 hospitals now, winnowed down over time until we're only looking at 1 or 2 hospitals in the state.
Thank you, Secretary. I am also in support of motion 2. I think the discharge threshold makes sense, and certainly the incentives for hospitals to have a positive trend makes sense. Only two comments. One about the data quality issue, which we've already discussed, and it is upsetting, although not surprising, to hear that hospitals that have certified filing reports now come and say, oops, we didn't really mean it. But given that, I would hope that the office would take refilings into account and come back to the board in the future to say, hospitals have corrected their data and our understanding of the world has now changed. I would second Dr. Pan's earlier suggestion that we certainly do look at this on an annual basis, at least for the next few years. I mean, so many things are changing. The data will change. We talked about hopefully having better measures on the outpatient side. And then the last comment, or question of clarification, the first line of this motion is set the hospital sector spending target equal to the statewide spending target. And just for clarification, if we were to not adopt this motion at all, that would still be the case. Is that true?
Sorry,
That even if, yeah, you were doing other things, that even if we did not adopt this motion, the first piece of it, set the hospital sector spending target equal to the statewide spending target, that would still be in place.
Correct.
And that's here only for kind of completeness and clarity. But is not if we were to say, no, we don't want this at all, that would still be true. Because we've heard a lot of comment about encouraging us, why are we singling out hospitals as a sector for special treatment? And I think it's important to note that there is special treatment to the 7 hospitals, if we were to adopt this motion, that would have a different target. But for all other hospitals, it is not special treatment. This is a target that's applicable to all healthcare entities in the state, not simply to hospitals.
That's correct, Dr. Cronick.
Thank you for that discussion. I'm actually, based on the comments of the board, would actually ask Elizabeth if you would entertain an amendment to your amendment. That being that we are looking at the annual revisiting of this, so that this concept that I think both Dr. Pan and Dr. Cronick raised around an annual revisiting is part of our motion.
I'm open to that. Are you talking about the transparency, the requirements?
That we're revisiting.
That we would revisit that annually too? Or that we just revisit the whole thing annually? I'm open to either, by the way.
Okay. I think we'd apply it across the board, so
Okay.
the whole section, if you're open to that.
Yeah, and just to clarify, you would be open to including compliance with the federal reporting?
Yes.
Okay, great. Then yes.
Okay.
And I have some language that I can provide.
Dr. Pan.
I guess they're working on the amendment, but I did have a question related to that amendment, which is, are we asking the hospitals to do something in addition to what they're required to do under federal law?
No, not under the amendment I just proposed or the one that Elizabeth.
Okay, I just want to.
Nothing new there. That the
Not,
board would revisit annually is the amendment.
yeah,
I'm
right,
suggesting.
yeah. So there's the revisiting, which is not, I think, as much of an issue as the additional requirement we're now imposing on the hospitals. Is that new requirement in excess of what the hospitals are currently already required to do under federal law?
If I could just clarify, it's not in addition. It's just that they are actually compliant with federal law because we're not seeing full compliance.
So Elizabeth,
Okay.
if I could, staff has a question about your proposed amendment and how we would implement it. So because we are not in a position to be implementing federal, and just to say, you all are, this is an open meeting where we are truly figuring this out as we go. So how would we as state staff determine federal compliance?
I think you could just ask for attestation that they're fully compliant.
We would ask the hospital
to attest.
And how would that relate specifically to the meeting of the target?
I'm simply trying to ensure that we have data available to us on hospital costs and pricing. And I think that data will become more important as time goes on and we are debating these same questions. Right now, there is a real challenge in compliance with federal requirements for transparency. So I just think if we are recommending exemptions, that I think transparency and full compliance will be helpful in ensuring that those are appropriate.
So Jean-Paul, I don't know if you and Ms. Mitchell had an opportunity, if you actually have language to propose, that would help, that would probably help us.
The language has been sent on to staff. So on number 1, it would start off annually set. That would be an amendment to number 1. And then number 3.
And we have staff input that the annual piece would be around the high-cost hospitals, not around, it's existing law that the hospital sector would be the statewide spending target. So we would propose the piece around annual assessment would just be related to the high-cost hospitals.
Yeah, essentially, if it's about kind of running this analysis every year. It could be a new number 5.
So there could be a new number 5 to have an annual reassessment of the data, but we would not want it in number 1 related to all of the hospitals.
Just read the.
But third item on the list, after in 2022, and attest that they are compliant with federal requirements, cost transparency as required. 2718E of Public Health Services Act. And then
So can staff request, make sure we're understanding it? So you're applying it to number 3. So it's just about whether to exclude hospitals? Ms. Elizabeth?
Ideally, all hospitals would be compliant and would attest, but I thought to be germane to this motion, it would apply to those who would be getting an exemption, but I could go either way.
And go ahead, Trish.
Oh, yeah, I think like operationally, we wouldn't be able to enforce that attestation. That's kind of a different regulator that's requiring that data submission to the federal government. So it's a bit of a jurisdictional.
Under the law, you can request that. You're just requesting that they attest, they engage in the transparency. I believe it was your original. I believe it was Member Mitchell's concern that we were sure the numbers they were providing were consistent with what they're providing to the Fed. So that would be just that they have used that federal standard to maintain consistency across programs. That was Member Mitchell's desire.
Please.
Elizabeth, I think I share your desire to have hospitals be as transparent as possible. The challenge I'm having is understanding if they're not, what's the consequence? I mean, here we're creating a list of high-cost hospitals that have a different target. We wouldn't want to keep a hospital off that list just because it wasn't compliant, right?
Well, I would, because I really think that it's not a very big ask to be compliant with federal law.
But then it gets rewarded for not being compliant if it stays off the list.
I believe what Elizabeth Mitchell is proposing is that hospitals would only be excluded under the exceptions in draft motion 2 if they attested that they had complied with federal law.
It's a condition, yes.
Yeah.
I guess given that there are only going to be 1 or 2 hospitals that are going to be excluded, in any given year, probably that would be excluded by this, it seems a little little kind of ice water or hammer and ice water problem. That we're creating a lot more problems for us and not getting much, not getting much reward. I mean, if we had a way to really strongly encourage hospitals to be, all hospitals in the state to be compliant, I'd be completely with you here.
Well, I'm happy to expand this to all hospitals. I just thought that we were talking about exceptions.
Yeah, I mean, I don't know what we can do for all hospitals. I guess I'm not sure of the suggestion. I'm just confused.
We're going to go to additional discussion here while the potential amended motion is still being considered. So I think Dr. Pan, you're next.
Well, all right. So one of the things is that also as I'm looking at this, I think I mentioned it earlier, is we're calling out specific hospitals. So we're not saying hospitals that meet these qualifications. So I think that could raise some issues. So I guess, I guess the question is that now, admittedly, Barton may still come off if we put some of our qualifiers in there. But for example, they said the data wasn't quite right. Now, I hear the response saying, well, no, they had to certify it was. But let's put it this way. A hospital comes to OCA and says, by the way, here's some data that we think has been misinterpreted or misclassified, right? And there isn't, and we don't seem to have indication that was out in ill intent or something. And after all, this is 5 years, right? Going back 5 years, right? So, and so are hospitals able to, I guess, update or correct their data for what could be, legitimate errors of interpretation or et cetera, right? Because, you say you have to report this and this, but exactly how that's interpreted is now in a different light given how we're now using the data. So for example, we just heard 2 examples up there. And at least to me, I'm not sure, didn't sound to me like, oh, these are people like really trying to warp the thing in a way that to try to get out. I think they sounded fairly legitimate, like, you know what, this got misclassified, right? And perhaps there wasn't really much consequence to the misclassification before, so they didn't bother to go back and et cetera, or, they said, one, use the vendor, right? So if the staff views that, hey, you know what, this it had a legitimate reason to say that the data was not exactly grouped correctly, right? And it's not like they falsified a number or something. Then is HCI or the OCA staff willing to, actually correct numbers or something? And by the way, this also starts talking about moving forward. Now, I think moving forward should be less of a problem because hopefully we're going to make it very clear to hospitals how we're interpreting and using the data. But that also leads to my question about people not being able to duplicate the results that we got using the same data set. So that's going to be important that people can duplicate the work that our office produced. But basically, I mean, errors will be made unintentionally. Can we correct those?
Yeah, I will just say any hospital can resubmit their data if they believe that there were errors made. These, I mean, as both you and Dr. Kronik have noted, these are attested for accuracy. Of course, mistakes happen. So we have communicated to hospitals that they can resubmit corrected annual financial reports.
So I think in that case, when I look at this motion, what happens is by calling out specific hospitals, we're actually saying you can't correct it because they said, no, actually there's a correction, and you go, okay, that's a legitimate correction. I run it back and you're not in there anymore. But our motion says your hospital name. It didn't say you meet these criteria. So I do wonder whether the motion should be phrased in terms of, I get the criteria is there, but instead of calling out the individual hospitals in there, right? So
it does include both.
Right, it does. conclude-
Pardon me, my mic was not on. Just to restate that, the motion that Secretary Johnson has moved both identifies the individual hospitals as well as the methodology. So if we had a hospital that resubmitted, there's an and as high-cost hospitals, as they are above 85th percentile, et cetera, that methodology, if we had a hospital that resubmitted and no longer met those criteria, then that they would not be included.
Okay, so I guess to me, it would make more sense to not actually name the specific hospitals in the motion and simply say, this is the methodology, and therefore, you've, based on the methodology from the numbers run by the offices over, the motion is you're on that list, right? And if it turns out there's a correction, then you come off the list. If, of course, it's the hospital, it's this office's judgment and this board's judgment, if that appeal or that correction is, something that we find is appropriate. So, but because the problem is now you have a confusion. If someone does drop out because there's a correction, the motion actually, if approved, actually still calls them out. So you'd still leave. So then one could argue, say, well, even though you don't meet the criteria, you were still named. So therefore you're still on the list. That's the conflict I see potentially coming up if there is correction.
I think in that circumstance, then just to go back to my clarity at the top, that we could revisit as a board if that circumstance were to occur. Is that correct?
Well, we'd have to undo our previous action if we actually acted by moving it, right? By not having it in the first place, but having the criteria, we would still have the same list right now. And if there was a fix, we wouldn't have to go back and fix our action with another board action to amend it to fix our problem. In other words, it would naturally happen because our motion actually just sets the criteria.
And the functional challenge, I think the reason that the staff drafted this motion as they did is that if we do have a hospital or multiple hospitals that have dramatically new resubmitted annual financials, we may have, that may change substantially, and we didn't think it fair to bring a new hospital onto the 85th percentile. And that's why we have named the hospitals, so that we're not adding new hospitals if there's a new data and that requires a new calculation.
Except the criteria are there, so they technically would still have to be added because they met the criteria.
The way the motion is written is it's these specific hospitals and the criteria. So we wouldn't have to add new hospitals upon a recalculation.
Okay. All right.
Ms. Mitchell, I just want to flag, so if your motion is, so as a staff concern, if the motion is for this year that they've attested, we don't currently hold those attestations.
That could
So
be for next year.
For next year. So where are we in terms of the drafting?
Can I ask a process question then? So these goals are for next year, right? 2026. So
Correct.
and I hate to bring this up, but if we're writing things on the fly, and of course, people in this room and maybe people watching are, but if we're going to add something pretty much brand new that we have not discussed before until now. Okay, I'm not saying that we haven't talked, but this is a new part. So all the other parts we've been discussing for like as you put in history, but this never showed up. Then perhaps it would behoove us, if this is going to be what we're considering, that we give it people a month to look it over, respond, and then we vote next month. Because this is a new item onto this motion that we have not discussed in our, we just had a presentation today of all what we discussed leading up to today, and that was not part.
Specifically about the
Yeah, the attestation part, correct.
Secretary, if I could get in the
Ian,
queue.
please.
Thank you. I wanted to maybe beat the dead horse and say this would be much simpler if we just specify no exemptions from this, from motion one. But given we seem to be heading to motion two, I 100% support transparency from the hospitals. I am unfamiliar with, I'm quite nervous about the complexity of the federal state interaction and all of that. It does give me pause to write that in at this point. So I'd just ask you to consider that too.
So in the interest of moving this forward, we've heard the urgency of taking action. I don't mind withdrawing my motion for today, but I will bring it back up because there is no excuse for hospitals to not be compliant with transparency rules that have been in place for years. And we need the data to be able to actually evaluate progress.
Thank you. So we have a withdrawal of the amendment that was proposed. We had an additional amendment that was proposed, which would be a new number 5. So the current motion on the table reads as on the slide, with an addition to number 5, which reads, annually, the office shall provide the board with an updated list of hospitals who are high cost and an updated list of factors to be considered in setting a hospital sector target.
I know we're doing a little bit of wordsmithing on the fly. Can we, instead of, because, and he says, so I agree with it. So you said annually, instead of just calling them high cost, meet the criteria for high cost. We will declare them high cost at the appropriate time, I think, as a board. But basically, we're asking staff to, using the process that we have, that's been laid out, that will be identified, so instead of just calling them high costs, let me just say that meet criteria for that.
I think we still want to say that the criteria is high cost. We need to know who's high cost. Are you comfortable with that? I just want to make sure I understand what you're suggesting.
I think that basically they meet the criteria as we described them
Yeah,
too, right? That's what it means. Instead of just declaring them high cost automatically, basically said that what happens, the staff is going to say, hey, we ran them. These are the ones who meet these criteria. And then we will decide, oh, you're high. Just like in some senses, we've kind of like, all right, well, so.
So I'm going to read it one more time with maybe a consideration of what you're suggesting. So the new number 5 would read, annually, the office shall provide the board with an updated list of hospitals who meet the above criteria as high cost and an updated list of factors to be considered in setting a hospital target, period. Yep, there's nothing else there. Yep.
I know, I can't, yeah, it's easier to see.
Please.
I would have thought it's an updated list of factors to be considered in adjusting or in determining high-cost hospitals. Is what I heard Dr. Pan suggest earlier and what makes sense to me. An updated list of factors to be considered in determining high-cost hospitals. Or in identifying high-cost hospitals, probably.
Give the team a moment to attempt to capture that.
Okay, and the English, not English teacher in me would suggest a list of hospitals which meet the above criteria rather than who, but that's quite minor. Updated list of hospitals, yeah. Yeah, that's fine.
Speak into the mic.
Sorry, yes, this looks right. Thank you, John Paul.
updated motion. I'm going to read it aloud again just to make sure everyone is. We have an updated motion here. Number 5 is added to the original motion on the slide as included. And it says annually, the office shall provide the board with an updated list of hospitals which meet the above criteria as high cost and an updated list of factors to be considered in identifying high cost hospitals. That is the motion that is in front of the board. I'll call one more time for any discussion on that motion. Seeing none, we will open it up for public comment.
We will now take public comment on this agenda item. Please step to the podium, or if you're attending virtually, please raise your hand. Please limit your comments to this agenda item, and please limit your comments to 2 minutes if possible. To the podium.
Beth Capel for Health Access California. Our preference certainly is for the first motion. We do understand the board discussion and the staff proposal as amended, but our preference is for the first motion. I want to speak, but more importantly, to the urgency of doing something and the importance of what you've already done by having a discussion about what high-cost hospitals are and what the implications are. You have gotten the attention of those who are or might have been subject to the high-cost hospital target in a way that helps with enforcement of the cost targets. The fact that we started the day with review of comments in which it became clear that some hospitals were unaware that they're currently subject to a 3.5% target enforces the need to take action and to do so urgently. I will say we have been troubled by the idea of decreasing trend as a factor, in part because we have concerns about data manipulation. And so we will continue to watch that very carefully. Some hospitals seem to have genuinely just not filed accurately. And we respect the staff's choice to allow them to resubmit, but we do find it troubling. We are hopeful that by taking this action, you will actually have the positive response we all want, which is that some hospitals that are extraordinarily high cost and are inflicting huge costs onto consumers will actually cease to be so extraordinarily high cost. These are hospitals that are twice as expensive as the average California hospital, and that means they cost 4 times as much as Medicare pays for the same care. Thank you.
Thank you. Looking virtually, Travis, go ahead. Travis, you're unmuted on our end, but we can't hear you yet.
Hi there. Sorry about that. Took a while to unmute. Again, this is Travis West, Regulatory Policy Specialist with California Nurses Association. We're also in support of Draft Motion 1 for the proposed hospital sector spending target values and are opposed to the inclusion of the discharge threshold at the 30th percentile. That would exclude smaller hospitals. The proposed exclusion appears to be linked to the number of beds and will not take into account where the hospital is part of a system that could be a significant driver of cost and other market dynamics. We're also opposed to the exclusion of high-cost hospitals that have shown decreasing values for 2 consecutive years. These high-cost hospitals are already well above average costs in the state, and just 2 years of declining price increases will not fix this disparity or establish a continuing trend. Finally, we want to again urge OCA to adopt and implement these standards as soon as possible. Notably, the spending targets are not caps on care, but rather caps on excessive profit making off of care by hospitals. High prices charged by hospitals increase out-of-pocket costs and insurance premiums paid by patients. It's OCA's role to address the unaffordability of care for patients. And the first step in identifying these high-cost outliers and keeping them accountable, or is identifying these high-cost outliers, as well as keeping them accountable to their communities and their healthcare workforces. Thank you.
Thank you. To the podium.
Victoria Valencia, Vice President Data Analytics at CHA.
Thank you for the opportunity to comment on data analytics, one of my favorite topics. And regarding the data sharing that OCA has shared for us, we're thankful for the transparency and sharing the general written instructions that we received to determine the high-cost hospital list. But despite this, we have been unable to replicate the list exactly in terms of the 11 high-cost hospitals. We also do not get the same exact dollar amounts for the unit price measure or the same exact percentages for the relative price measure. While OCA did share some analytical code, they only share code that takes a data set that they provided with the 2 high cost measures already calculated by hospital and by year. And the code just takes those data and creates a list of 11 hospitals. So what they did not share is full analytical code used to calculate the measures, nor the code that details the exact columns from the AFDR publicly available data set used to calculate the measures. So as such, we're unable to check their work in terms of calculations, rounding, or what exact function they used in terms of calculating the 85th or the discharge weighted 85th percentile for each measure. Thank you.
Thank you. Looking virtually, Mark, go ahead.
Hi, can you hear me?
Yes, we can. Go ahead.
Okay, great. Thank you very much. Yeah, Mark Bale, President and CEO for North Bay Health, and I'm actually one of the hospitals that's been identified as the high-cost hospitals. And so I appreciate the board giving me an opportunity to make some comments. I'll speak specifically to draft motion 2. We're obviously very supportive of the fact that there is changes that need to occur within the model of healthcare. I think one thing we could all agree on, and we've heard a lot of public comment on both sides of this today, is that the system is broken. You would hear that from the hospitals, you'd hear that from consumers, you would hear from payers, you would hear from employers. 40% of hospitals across the US are underwater. 60% in California are underwater. And so what we're really, I think, trying to discern today is how do we fix it? What do we do about it? And simply by sort of reducing the amount of resources that a healthcare system has to use to take care of, and in our case at North Bay, the most vulnerable populations throughout Solano County. If we take care of 60% of all of the underserved patients who need to have labor and delivery services in this county, we constantly show up whenever it's needed. We saw the first COVID patient in California, in the country, that was seen at North Bay Health by request of Travis Air Force Base. We simply don't ask questions about who your employer is. We don't ask questions about whether you're part of our closed network. We simply just open our doors and say, we will take care of you regardless of your ability to pay. And the fact that is that most of the rewards, incentives, and penalties that we face as a healthcare system are really talking about when we take care of people when they're sick, when they've had a trauma event, or when they need healthcare. And that's really what drives the cost of care up. It's the complexity of care that's being delivered at the time it's being delivered. If we really want to talk about reducing the cost of care and making it more affordable, we really need to focus our attention on how do we get upstream and how do we start to develop rewards, incentives, and penalties, for really taking care of patients, before they have these conditions, before they need that care. And that's really focusing on preventive measures. And I heard some talk today about capitation, global capitation, putting hospitals at risk to deliver care that was when needed, but also to develop additional ways to go upstream to take care of patients and to make it more affordable. So I would just
30.
I would just ask that you consider these as you're reviewing some of the action you take today. So thank you very much.
Thank you. To the podium.
Ben Johnson with the California Hospital Association. First, would just reiterate the concerns laid out by my colleague who runs our data analytics and has not been able to replicate the findings from in terms of who is a high-cost hospital, an enormously impactful difference in terms of which hospitals would be subject to a spending target 50% below the spending target. Second, would just note that the consequences of this board's decisions are enormous, and yet the board is taking huge decisions potentially on the fly without proper and due consideration. It's also doing so on the same day as it's reviewing the comments that were received on the sector target proposal. Not enough time, in our view, to really ascertain and deliberate over the comments that were received around the appropriateness of the methodology or the impacts for patients. So otherwise, I'd just like to reiterate the comments of all the hospital members that testified here today, that this proposal is going to create real harm that can't be addressed on the back end. They are going to affect contracting, where patients across the state are going to lose their usual source of care, as has already occurred even under the statewide spending target. There's the reputational harm that a colleague of mine or a member also discussed, and the ability of these hospitals to adequately plan for the future, provide for the increasing needs that Californians who are aging and who have various health challenges are going to need over the next several years, is going to be severely impacted by this decision. So again, ask the board to I ask the office to withdraw its proposal, board to reject this proposal, and reconsider at a later time. Thank you.
Thank you. Looking virtually, Jason, go ahead. Jason, we can't hear you yet on this end. Can
All right,
you?
are you able to hear me now?
Yes, we can. Go ahead.
All right, good afternoon. Thanks for the opportunity to speak before you today. I come before you for the first time as a resident of Monterey County, a teacher in the Salinas Valley, and as someone personally affected and deeply concerned by these continuing shady billing practices at Community Hospital of the Monterey Peninsula. I want to share with you today about some real human impact behind these grotesque billing practices that are happening at CHOMP, and share something personal, something that I think underscores why this issue is not so abstract for me and my family, and to urge you, the board, to follow through with your proposed motion to define these sectors for the highest charging hospitals. On January 10th, my wife went to CHOMP for routine pelvic ultrasound, x-ray imaging. We did our research ahead of time. The average cost across the state was a little bit around $2,000, and we received a staggering bill of $4,879, more than double what we were expecting to pay. She had her most recent visit to CHOMP on April 9th, where 2 days prior to that, CHOMP's billing department called her and strongly encouraged her to pay around $500 up front without any explanation, just simply a demand to pay more money. Luckily, she declined, and she waited until after services were performed. She saw her obscene bill on the MyChart app, and then followed up by asking them for an itemized bill, where suddenly and magically hundreds of dollars disappeared from her account on the billing statement, and her amount owed was magically reduced. So I just want to say that's not really how a fair and transparent billing system operates. It's not how our patients should be treated. And we really can't pretend that this is normal, and we can't expect patients, especially our most vulnerable ones, to navigate these inflated costs and fragmented charges on their own. It's not really about blaming the institutions, but it really is about standing up for Californians like me, like my wife, and many others that are affected in Monterey County. And it's about ensuring that no one has to choose between financial survival and medical care. We need accountability from you. We need transparency from our hospitals. We need leadership, and we need bold action. The people of Monterey County and across the entire state are counting on you. So please support this motion. And thank you for your time. Thank you for your commitment. And thank you for standing with the patients who need you the most.
Thank you. To the podium.
Members of the board, staff, Steve McDougall of CFT and from Monterey County. Please take that comma out of the fifth part of the motion. As a teacher, you gotta get that comma out of there. It doesn't belong in there. Trust me. All right. Okay. I'll yield the balance of my time to nobody else but me. So anyways, that being said, as president of MCSIG, we're going to have our meeting this week on Thursday. And it's the first look to let the employers, the chief business officials, management groups in our self-funded JPA, to know what to budget for healthcare next year. And I came to you last year, said we were looking at 17%. We got it down to a little over 12 by passing off the cost of care upon accessing it when they go get it, reducing benefits. And we have a professional actuary that has a heck of a book of business, not only in California, but across the country. Even handles employee benefits for some of the hospitals involved in the discussion today, believe it or not. So we have a pretty good actuary, and we've come up short 2 years in a row on revenue. We have months of over 100% loss ratio. Waiting another month, filibustering, kicking the can down the road. Oh, we're confused. We need time to think about it. Is another month for 100% plus loss ratio for our folks. Not one more negotiated raise should go and be transferred or funneled to a hospital provider entity in the end. It's got to stop somewhere. Do the right thing. We're with you in spirit and physically here as well. Thank you for your work and your decision.
Thank you. Looking virtually, Ryan, go ahead.
Good afternoon. Thank you, Ryan Witz, Executive Director for the District Hospital Leadership Forum. Just a quick comment. You know, the discussion today was helpful, and but although most of it happening on the fly and virtually was rather difficult to follow, it's unclear whether anyone responded to Dr. Pan's question, whether a hospital listed in motion 2 that corrects their data will have the opportunity to fall off the 26 high cost list should they no longer meet the criteria. As staff have presented, a decision today is not required. There is additional time for this board to bring it back in May, and we ask the board to consider that. Thank you.
Thank you. Back to the podium.
Everyone has sharp brain cells after that Earth Day oxygen breathing exercise at lunch. Katie Bassler from Salinas. I want to begin with gratitude to all of the members of this board for the work that they have invested over the past 2.5 years to slow spending growth, promote high value, and assess market consolidation. I've been attending these meetings, almost all of them, for just about 2 years, urging you to address the dire state of healthcare in Monterey County. Simply put, the residents of Monterey County can't afford healthcare. And we're a captive audience in what Dr. Pan referred to as an ecosystem. We urge the board to vote for that lower spending target in motion 2. Your slides define the spending target as a framework for hospitals to manage growth in price, volume, or both, and therefore challenging hospitals to engage in efforts to improve the affordability of healthcare. That is what we are asking. Monterey County residents needed help years ago, and we now ask that the board adopt these lower spending targets because there is urgency. Thank you very much, and I respect all of you.
Looking virtually, noting for the record that we have about 100 virtual attendees, seeing no hands raised virtually, going back to the podium.
Good afternoon, Maya Schneider with Marshall, El Dorado County. I just want to acknowledge the really thoughtful discussion this afternoon. I appreciated the amendments that were considered for the motion. Shy of our preference to really make sure the data is correct and the methodology reflects the reality on the ground, we are supportive of the motion as it stands now on the table and urge a yes vote on that. Thank you.
Back to the podium.
Good afternoon, Joan Allen of SEIU United Healthcare Workers. Thank you so much to the staff for the months of hard work that has gone into getting us here today. The incredible iteration in response to hours and hundreds of pages of public comment is reflected in the motion you see before you. We, whether it is in these meetings, the advisory committee meetings, or the public comment that occurs between, we have seen the urgency. We have seen the need, and I would encourage you to act today to put us on what is really a historic path. While I would have honestly preferred option one, option two still takes us down that road, takes us down the road of being able to really start addressing those high cost outliers and sets us really looking toward the future of what will that next iteration be as well, but would encourage you not to wait and to move forward today.
Thank you. Continuing at the podium.
Ivana Krejcinovic, Unite Here Health. I want to talk a little bit about primary care. We took a look at our data, and we noticed that in the Monterey County area, that independent primary care physicians are being paid under 100% of Medicare, actually averaging about 84% of Medicare. The ones affiliated with hospitals do a little bit better in the 115 to 120% range. We've definitely reached out to Anthem to ask why they're underpaying primary care physicians so significantly, and we can only guess that the reason is that so much of the healthcare dollar is getting sucked up by the hospitals that there isn't enough money left for the PCPs who are best positioned to keep people out of the hospitals, ironically. I just want to say that I find it amusing that we're talking about rushing and doing things on the fly after this very long process. I think Joan said it, better than I could about how deliberative this has been. We looked at RAND studies, we looked at our own data where we're paying 400% and 500% of Medicare, twice what we pay in New York City, 3 times what we pay in Chicago. This is not about math. This is about an industry, a very small sector of the industry trying to preserve outsized profits, and the time to end it is now. We had originally hoped that the proposal would be for a 0.1% increase, and we would have also liked something more like option one, but in the interest of moving ahead and allowing this board to turn its attention to the many other parts of healthcare costs that you need to still figure out, we really hope that you can vote today on the new draft motion 3. Thank you.
Thank you. Looking virtually, seeing no hands raised, looking to the podium.
Hi, sorry, Clement Miller again. I'll be quick. I wanted to touch on the primary care topic that was just brought up. As we have discussed with the board at a number of opportunities, and I say we, I'm mentioning Salinas Valley Health, we really need to be seen as a system. Our hospital subsidizes our network. So the 115% of Medicare that our primary care physicians are getting is obviously under what they should be getting paid. Our healthcare system is subsidizing them through the profits from the hospital. Cutting the profits that the hospital is able to make will have an impact on the care that we're able to provide and the access to care that our community has gotten used to, and we're really working to improve. Really looking to bring in more physicians to support the need in our area. But if we are unable to provide the financing for that service, because we're continuing to have lower rates of reimbursement for that care, we're going to struggle providing the care. So I just thought I'd add that 2 cents to your deliberations. And I would ask, just as others have asked, that we hold off on this. January is when this is going to hit. There's no reason to make a decision today until we've really gotten to a place where we truly understand what the outcome of this decision will be. Thank you.
Thank you. Looking back online, seeing no hands raised, noting for the record, we have about 100 virtual attendees, seeing no one at the podium. That concludes public comment on this item.
Thank you for the additional public comment. I will ask for a roll on the motion.
Dr. Sandra Hernandez?
As amended.
Do you want to restate it?
I would like to have the roll called on the amended motion.
Dr. Sandra Hernandez? Secretary Kim Johnson?
Aye.
Richard Kronik,
Aye.
Ian Lewis,
Aye.
Elizabeth Mitchell,
Aye.
Dr. Richard Pan,
Aye.
that's our voting members. That's 5 ayes. The motion passes.
Again, thank you so much to the staff. Thank you to the public in the engagement of this process. This is again, a next step in the phase of our conversations and the work that we have as a board. So just really, again, appreciate the engagement and that dialogue and the continued dialogue we will have moving forward. With that, I will like to turn to item 5C, the update on cost and market impact review program, and invite Assistant Deputy Director Sheila Katayan. Thank you.
Good afternoon. Can you hear me okay? I know there's a little bit of feedback with these mics. So feel free to take a deep breath, sit back. This is a lot more, I would say, relaxing. You get to listen. So for our update on the cost and market impact review, I'm very glad to be standing in front of you today because April 2025 marks a year since we began our program of accepting notices of material change transactions. So if you remember, April 1st, 2024 was the statutory date that healthcare entities had to supply 90 days advance notice of any material change transactions. And you worked with us on our regulations to get us to the point that our program would be able to start on April 1st, 2024. So here we are in April 2025. So next slide, please. So since that time, I put together a little graph for you. You can see that from the time period from April 1st to December 31st, 2024, we received notice of 10 transactions, okay? And then what I want to explain to you is that with the 10 transactions, that's not 10 notices because there are often multiple submitters that have to provide notice to us for the transaction. All right, so healthcare entities have to provide notice of a transaction if they meet the threshold monetary requirements or the HPSA, Health Professional Shortage Area requirement, and meet the monetary revenue thresholds. So there can be several submitters for a single transaction. So you'll see that we had 10 total transactions with 16 different submitters. So that means we're looking at multiple submissions for a single transaction. And then as it was our first year handling these notices, you'll see that we conducted 26 pre-filing meetings with submitters. We do not require a pre-filing conference, but many of the attorneys who represent their clients came to us and asked if we would meet with them, and we were happy to meet with them so that their filings would be clean and they could understand the process and all of the regulatory requirements. So that takes us through the end of December. So then starting in January, we received, since that time, since January, we've received 6 transactions. And you'll note that with just those 6 transactions, that constituted 10 different submissions. We think folks are getting the hang of the filing and our portal because we've only had 3 pre-filing meetings so far to date. So to date, we've had 16 total transactions. Any questions on that slide? Okay, great. Thank you. All right. Next slide, please. All right, so what kinds of transactions are we seeing? You'll see that the largest number of transactions we've received are in the skilled nursing facility. A lot of acquisitions in that space. And then the rest are pretty equal. 3 laboratory transactions, 3 transactions involving physician organizations, 3 involving health plans, plus a physician organization or health plans plus a hospital, and then 1 FQHC. So that's the breakdown of our 16 transactions that we've received so far. Any questions or comments on that? Okay, next slide, please. All right, we've had this question before about what about transactions that aren't filed with you? How do you hear about them? What do you do to find out about them? Well, we do try to track a lot of public information on an ongoing basis. We also work with other state agencies under our agency, including California Department of Public Health, the DHCS, Department of Managed Healthcare, and we also work with the AG very regularly. We also receive messages in our CMIR inbox, Cost of Market Impact Review inbox. And so with that information, what we'll do is if we hear about a transaction that we think should have been filed with us but was not, we will draft a letter, send it out to the entities that we believe or have found information and we suspect that they were involved in the transaction, and we'll remind them of our requirements and ask for an explanation as to why they didn't file. And that has been fruitful because of the 13 transactions that we did hear about, we identified all of those 13, and then one has resulted in an actual submission. Others we determined were not within our jurisdiction, and we were able to notify the other agency who had jurisdiction to make sure that they were aware of the transaction. So I just want to point out, and the last item on this slide for the public is that you can notify us of transactions that you hear about that you may think are subject to our review, and you can contact us through the email inbox address listed on the slide, cmir@hchi.ca.gov. Okay, next slide. So how do entities know that they need to file with us? This is a condensed flow chart of what appears on our website. The actual flow chart has much more detail, but this gives you an idea of a decision tree. And the decision tree is pretty comprehensive, and it walks a potential submitter through questions, and as they answer the questions, yes or no, it guides them to whether they have to file with us. We have heard that this has been very helpful to potential submitters. So at your leisure, you can look at that if you're interested. We also developed frequently asked questions, which are on our website, and the link is in the presentation, and you can see it right there. Next slide. So as we've said over and over in these meetings, all of the notices are available on our website, and there's the link. We post the notices that we receive once we determine that the filing is complete. So once we receive a filing, we make sure that it contains all the information as required by regulation, and once we determine that it is complete, we post the notice on our website. So to date, we have issued waivers for all of the transactions that we have reviewed. And by that, I mean, we have gone through the 45-day review process of the transaction, applying our 9 factors for consideration to determine whether a cost and market impact review is necessary. And so far, we've not ordered any to a full cost and market impact review because they didn't meet the 9 factors. For comparison's sake, I've got on the slide to show you Massachusetts, since 2013, has reviewed 180 transactions and sent 6 of those 180 to a full cost and market impact review. Oregon is newer in its program, just a couple years ahead of us. We actually do talk to our state partners occasionally. Oregon told us recently that their total transactions reviewed are 51, and of those 51, they have completed 5 comprehensive reviews. And comprehensive reviews is their term for a full cost and market impact review. Looks like there's a question.
I know Oregon's been at this for longer than California, but it's also a teeny fraction of our size. So the comparison of 51 filings in Oregon and 16 here, what is the difference in the thresholds, or what's exempt that accounts for that?
Yeah, 51 for them is because they have other types of healthcare entities in their jurisdiction. For example, they have home health, they have hospice, they have other types of healthcare entities that are not under OCA's jurisdiction. So they are seeing more submissions.
Do they similarly exempt transactions that are from nonprofit entities that are reviewed by another state agency?
I do not know the answer to that. We can check that and see. They do work with their AG, but I don't know if they have an exemption process with that.
Thank you.
Next slide. All right. This is a slide just to illustrate how complex the corporate entity structure of many of these companies who are entering into these types of transactions. These are fictitious names with a sample organization chart. And the sample is modeled on a variety of transactions we've seen. So in this one, you'll see that Mediterranean Health is quite a large organization with lots of subsidiaries, lots of LLCs. And within Mediterranean Health, you'll see the dotted line where Mediterranean Health Management is acquiring S&H Health, Inc. And you can see the corporate structure of S&H Health, Inc. And if you look closely, I know that the text is very small, but you'll see that S&H Health, Inc. does have some foreign holding company in the Cayman Islands. It has a sort of horizontal set of subsidiaries. And you'll see that there's in addition to the foreign investment, there's individual ownership with a fictitious name MD at the top. So this is just to give you an idea of the types of corporate structures we see when we're reviewing these transactions. Okay, next slide. Here's another slide, and this one really shows you how many holding companies can be involved within an organization. So in our SNF transactions, we often see a new single-purpose entity created specifically for the transaction. So a corporation will create a new single-purpose entity, a holding company, and the holding company is going to acquire a skilled nursing facility, and the percentage of ownership you can see kind of floats all over the large organization. And here, as you see, you've got a doctor who owns just 5%. The very top right, you've got shareholders. So there can be investment and ownership of all degrees with multiple holding companies. And this is not unusual. I would say that this is not unusual throughout the country in terms of skilled nursing facility ownership by several large companies. All right, so this is just a quick review on the transactions, and these are all on our website. So the newest transaction that's on our website is West Coast Hospitals, and that is another SNF acquisition. So we deemed that submission complete just recently, April 7th, so it is in review. And then as you see, I mentioned that we had 6 transactions for this year. Two of those 5 that are still in review, we just started the clock on, so you should see those on our website pretty soon. So that accounts for the 6. We started the clock on another one, so there's probably 2 on the website, and another one will start soon, so that'll be 3 of the 6. Then there'll be 3 waiting to go up on the website once we determine the submission is complete. All right, next slide. So these are a follow-up to transactions you heard about in January because they were deemed complete and they were on our website as of December. So the first one, CSI Medical Group, submission was in December. We waived that transaction in February. And that is a physician organization or physician practice, dermatology. And you'll notice that that involved a couple of different physicians, and it also involved California Skin Institute Intermediate Holdings. And it's public information, public record that is, there's private equity ownership in that. And the California Skin Institute Intermediate Holdings does encourage dermatology practitioners to join its organization and receive the benefits of some investor backing. So for Korean American Medical Group, you've heard about that one before. That is another physician organization combination. And that one we waived in January of 2025. And we don't typically include, well, we don't include the waive date on our website. I'm just showing them here so you can see that we are within the 45-day time frame for that and about how long it takes us to do that. Next slide, please. Ambry Genetics and Tempus, you probably also remember. Tempus acquired Ambry. They were in the same kind of testing and for cancer genome, and they were looking to expand, but it did not rise again to warrant a full cost and market impact review. So we waived that transaction at the end of January. Next slide, please. So I'm going to call out Alexandria Care at the top, and then can you go to the next slide? Because Sharon Care on this slide, then go to the next slide, Alta Gardens Care. So Alexandria, Sharon Care, and Alta Care are all skilled nursing facility acquisitions. And you can look at your computer or you can look at your papers, and you'll notice that in each of those transactions, there's a bold quail or BQ holding company. It's not the same holding company in each transaction, but bold quail has multiple holding companies. And they are for the purposes of acquiring the skilled nursing facilities. So again, you can look at the public notice on our website, and you can see that there's just a lot of activity in skilled nursing facility acquisitions. All right, let's go back a couple slides. So Prospect Health and Astrana, you may have heard about that in the news. That was a very large transaction. For $745 million, Astrana acquired certain aspects of Prospect, including the health plan and including multiple medical groups, 8 IPAs, a specialty mail order pharmacy, and a MSO. You'll notice that the submission was complete on January 28th. We didn't waive it till April 3rd because this one took a fair amount of time to review. And I will say it's the first one where we exercised our right to request additional information. So our process is we receive the notice, we determine it's complete, we start the clock, we have 45 days to review. During that 45 days, we can stop the clock if we feel and identify the need for additional information. So we did that in this case and went to the parties to request additional information, very detailed information. And I will say they were very prompt in getting it back to us, which I'm sure they would want to be because they want to close their transaction. So after reviewing the additional information and looking at it as a whole, we ultimately waived that transaction. All right, next slide. And then Agile Akeso, that is occupational medicine, 2 groups combined, and we waived that transaction in early March. That should complete the transactions. Let's go to the next slide and be sure. Yep, because we already went over Alta Gardens Care with the combined SNF transactions. Any questions? Doesn't look like it. All right, thank you.
Thank you very much. Just checking one more time for
Can you check the mic?
questions from the board. Okay. And we will call on public comment for this item.
We will now take public comment on this item. Please step to the podium or raise your hand looking to the podium. Go ahead.
Beth Capel with Health Access. Given the action the board took earlier today and the many predictions of dire consequences, I just want to remind the members of this board, most of whom were here when we adopted the requirements for CMIR, that you similarly heard many dire predictions about the implications of CMIR and how you would be overwhelmed by transactions. I would say to the contrary, I am surprised at how few, I continue to be surprised at how few there are, although there are always fewer when interest rates are higher. So I think I take from this and the care that the staff is exercising in reviewing the transactions, a confidence that the action you took earlier today, you will also be able to conduct fairly and effectively. Thank you.
Looking virtually, seeing no hands raised, noting for the record, we have about 73 virtual attendees. Seeing no one at the podium that's there to make public comment. All right, that concludes public comment.
How are we doing? There we go. All right, perfect. Thank you very much. We are going to, just for the good of the group here, we're going to push item 5E, the update on the behavioral health definition and investment benchmark, including advisory committee feedback, to our next meetings. Just want to make people aware of that. And now welcome Assistant Deputy Director Brandt to give us an update on the quality and equity performance measurement and also advisory committee feedback.
Good afternoon, members of the board. Margaretta Brandt, Assistant Deputy Director for Health System Performance. So in this portion of the agenda, we will provide an update on the OCA Quality and Equity Measure Set. And joining me this afternoon is Jana King, Health Equity and Quality Performance Group Manager. So if we could move to the next slide, as we usually do, we'll start with a reminder of the statutory language that guides the Quality and Equity Measure Set. So it indicates that the office adopts the Quality and Equity Measure Set and that performance on the measure set must be included in OCA's annual reports. It requires OCA to adopt and track performance on a single set of standard measures for assessing quality and equity across payers, fully integrated delivery systems, hospitals, and physician organizations. And these measures will be used to monitor quality and equity trends as healthcare entities work to meet spending targets. The statute requires us to use recognized clinical quality, patient experience, patient safety, and utilization measures, and to consider available means for reliable measurement of disparities in healthcare, including race, ethnicity, sex, age, language, gender orientation, or sexual orientation and gender identity, and disability status. It directs OCA to reduce administrative burden by selecting quality and equity measures that simplify reporting and align performance measurement with other payers, programs, and state agencies, and to rely on existing reporting to the greatest extent possible. It also directs OCA to coordinate with DMHC, DHCS, Cover California, and CalPERS, along with other external organizations, advocates, and other stakeholders. So if we can move to the next slide, this is again recapping the statutory requirements, especially related to our authority to enforce performance against the Quality and Equity Measure Set. So although OCA does not have standalone authority to enforce the performance on the Quality and Equity Measure Set, OCA's progressive enforcement of spending targets will consider impacts on quality and equity and may consider healthcare entity performance on the OCA Quality and Equity Measure Set. Specifically, OCA's enabling statute prohibits the director from approving a performance improvement plan that proposes to meet the spending targets in ways that are likely to erode access, quality, equity, or workforce stability. And accordingly, the director may consider performance on the OCA Quality and Equity Measure Set when approving or disapproving a performance improvement plan. If we move to the next slide, just as another refresher, the purpose of the OCA Quality and Equity Measure Set is to promote high quality, equitable care for all Californians monitor changes in quality and equity as healthcare entities work to meet the spending targets, and track progress towards OCA's goals to improve access, affordability, and equity for all Californians. And on this next slide, we'll review, sorry, I think we may have skipped a slide. Could we go back one? Oh, sorry about that. So this slide provides an overview of our progress to date. So OCA is adopting the quality and equity measure set as required by statute, and will regularly review and update it also as required by statute. So this slide provides an overview of our process and our progress for adopting the OCA quality and equity measure set. And we wanted to highlight our work that we've done so far since fall of 2024 up to today, and what you can expect in the future. So in October of last year, we introduced our proposal to the advisory committee for feedback. And then in November, we introduced our proposal to you all at the board and gathered feedback. In January, we provided an update on our proposal to the advisory committee for feedback. And then we shared our proposed quality and equity measure set for public comment as well. And then in March, we shared another update with the advisory committee. And as you'll see emphasized here, OCA will present a recommendation for hospital safety measures to the advisory committee and the board in fall of 2025. And then leading up to June 2027, OCA will publish its first annual report with quality and equity performance results. So now we can move to the next slide. So this is a high-level overview of the OCA quality and equity measure set. OCA is adopting all or a subset of 3 publicly available measures and their respective stratification or grouping requirements to measure quality and equity across healthcare entities. For payers, we are adopting the full Department of Managed Healthcare, or DMHC, Health Equity and Quality Measure Set and its stratification requirements. For physician organizations, we are adopting a subset of the Center for Data Insights and Innovations, Office of the Patient Advocate, or OPA, Healthcare Quality Report Card measures. And for hospitals, we are adopting the full HCI Equity Measures Reporting Program measure set and its stratification requirements. Fully integrated delivery systems will be measured across all 3 measure sets. And we will apply the same benchmarks used by each measure set to evaluate performance of healthcare entities. And as I noted earlier, in fall, after collaborating with sibling departments, OCA will present a recommendation for hospital patient safety measures. And we'll share more details about this process later in today's presentation. And in addition to adopting these measure sets, OCA will continue to explore including additional equity analyses beyond the stratification requirements by demographic characteristics that are used in each of the respective measure sets. And in the next few slides, we'll review the measures included in the OCA quality and equity measure set. So this slide and the next slide show the measures included in the measure set. So these include some of the best available access, behavioral health outcome, and patient-reported outcome or patient experience measures for payers and physician organizations. The first 4 measures are also included in the OCA Alternative Payment Model Standards and are aligned across DMHC, DHCS, Covered California, and CalPERS. We also want to note that the process measures included here focus on prevention and align with OCA's work promoting investment in primary care. We also want to note that we anticipate that the payer and physician organization measures that we are adopting will become more aligned as measures are added to the OPA healthcare quality report cards over time. And if we move to the next slide, this slide reviews the measures that we are adopting for hospitals. So again, these measures include some of the best available behavioral health outcome, patient experience, patient safety, and structural measures for hospitals. Of note, there's one dedicated safety measure, as well as additional measures that promote overall patient safety. And as we noted before, OCA will present a recommendation in fall 2025 for incorporating more hospital patient safety measures after collaborating with sibling state departments. And now here, I want to turn it over to Jana King to provide a recap of the public comment, advisory committee, and board feedback that we've received over the past several months, and background on our ongoing work to collaborate with sibling state departments on hospital patient safety measures.
Thank you, Margaretta. Hello, everyone. My name is Jana King. I'm the Health Equity and Quality Performance Group Manager at OCA. I use she, her pronouns. So this slide, and we can go to the next slide, please. This slide is a high-level summary of the public comments we received during the public comment period from January to February, and the feedback received during the recent advisory committee and board presentations. Public comment and advisory committee or AC members shared general support for OCA's alignment with publicly available measure sets. Public comment AC and board members suggested adding healthcare associated infections measures and/or other hospital patient safety measures. Public comment AC and board members recommended additions, modifications, and removal of measures. Public comment AC and board members encouraged more stratification requirements while noting challenges in collecting demographic data. Public comments recommended changes to the stratification requirements. Board members had a question about reporting and enforcement. Public comment requested that OCA consider innovative ways to utilize data for reports and delay or change public reporting requirements for some measures. Public comment AC and board members noted some limitations of the OCA quality and equity measure set. And we want to note that OCA will regularly review and update its measure set over time as required by statute. And that as DMHC, OPA, and the HCI Hospital Equity Measures Reporting Program measure sets are updated by their respective owners, OCA will update its measure set as well. OCA also intends to monitor new measures under development and consider incorporating these measures into its measure set. Also, OCA will monitor efforts to improve demographic data and stratify more measures. For physician organizations, OCA will collaborate with OPA and IHA to explore opportunities to publicly report stratified measures. More generally, OCA intends to support and monitor efforts to advance health equity and reduce health disparities in California. There are summary tables with more detail on the feedback we received and OCA responses in the appendix slides for your reference. We can go to the next slide, please. Okay, so as Margaret had mentioned, also OCA received feedback to consider adding healthcare associated infection or HAI measures to the OCA quality and equity measure set, and more broadly to consider adding more hospital patient safety measures to improve OCA's ability to monitor patient safety as hospitals work to meet spending targets. So in response, OCA will collaborate with sibling state departments, including CalPERS and Covered California, that are currently working to develop a priority set of hospital patient safety measures, including consideration of healthcare associated infection measures. The goal of this effort is to create an aligned approach to hospital patient safety measurement across state agencies. OCA will review this priority set of hospital patient safety measures from sibling state departments and will reconsider adding healthcare associated infection measures and potentially other hospital patient safety measures to the OCA quality and equity measure set with input from the advisory committee and board in fall 2025. You can go to the next slide, please. Okay, and this is the last slide that I have. This slide provides an overview of how HAI healthcare associated infections are currently being tracked and reported across different state departments. The California Department of Public Health, CDPH, is required by statute to oversee the prevention, surveillance, reporting, and response to healthcare associated infections in California's hospitals and other healthcare facilities. CDPH HAI measures include those shown on the slide in the dot point list. One important note is that while CDPH actively tracks these HAIs, it does not stratify HAI measure performance by demographic characteristics. Other state agencies are also prioritizing hospital patient safety through their contracts. The Covered California 2023 to 25 contract requires health plans to work with hospitals to improve performance on the same 5 HAIs as CDPH, though Covered California has removed a specific hospital measure list in the 2026 to 28 contract. Similarly, the current CalPERS contract emphasizes improvement on 6 HAIs, 4 of which overlap with the CDPH HAIs, though these specific measures may be removed in future contracts. Thank you. We're happy to answer any questions.
Dr. Penn.
Thank you for the presentation and really appreciate all the work on the measures. A couple of questions. So, because I know this is on quality and equity, so we'll start with the quality half first. So I'm a pediatrician, so I'm looking at the well-child visits, which is basically the first 30 months of life. Now, the reason I'm sort of looking at that is, interesting enough, when the auditor audited the Medi-Cal program, they noted that actually a fairly low percentage of children got their well-child visits. But what was even more noticeable is that what happened is that on the visits where they were actually measured for the quality, actually it was fairly high, and all the other visits it was very low. So what it means is that when no one's looking, right? So I guess and again, I fully agree, and we've talked about this before. We should try, everyone should line up, right? We don't want different measures, different groups. So we should be lined up with DMHC and DMA, and then as well as Medi-Cal as well. But is there a reason we're not looking at the entire schedule to be sure that every visit is measured instead of, and the reason I bring that up is because of what happened with that audit, which basically showed that when people thought we weren't looking, they didn't do anything about it. They focused their efforts only on the things we're measuring.
So I can start. I think the key here is, as you mentioned, Dr. Pan, is focused on alignment. So we are adopting the child pediatric focus measures that are included in the DMHC and OPA measure sets. And of course, as those measure sets change and adjust over time, we can collaborate with the DMHC and with OPA to consider adjusting and adding to those measure sets to incorporate different pediatric measures as they update their measure sets.
Okay. Well, I appreciate that, and I hope we will advocate at least because actually the first 30 months is usually when performance tends to be a little better, although it's shockingly how low it was even for those visits when the auditor looked. And by the time you get to mid-childhood and teenagers, it completely falls off. But so I just throw that out there. But also keep in mind the things we look at are usually the things people will pay attention to, and the things we don't. So I appreciate that. So on the equity side, right, because we have all these safety measures here, and part of the equity side is of course seeing disparities, right, by race, ethnicity, or other types of measures. So what's not listed on here, but theoretically you're supposed to collect, people are supposed to collect it, but we also know sometimes the data collection is so great. Is there some thought in terms of, again, because we're all sharing the measures together, to make a concerted effort to be sure we actually collect the racial, ethnicity, maybe sexual orientation data that they're supposed to collect, so that we can actually do the analysis on the equity side? Because you can have all these measures, if you don't have that other measure, you can't find the disparities, right? Because you don't, there's too much missing information. And I think we did touch about SPD 15, so they were changing the way doing things, although, so far the current administration has not undone that. That's still the rule. But also thinking about what kind of efforts, obviously it's not us alone. In fact, it's probably going to be more on DMHC, OPA, and DHCS, but really about what some strategic concerted efforts to improve that data collection. I know what it's like being a frontline provider, doctor, and sometimes people don't want to ask, or et cetera. But what can we try to do to get that data? Because obviously, if there's a low response rate on that, we can't do the equity analyses.
Dr. Pan, I'm happy to start with that and then give the team a chance to add, because I couldn't agree with you more, and it's such an important issue. And actually, I was talking to Mary Watanabe, the director of DMHC, about this yesterday. So it's a personal frustration of mine that we don't have better race, ethnicity, and language data. And language is particularly inexcusable because you can't provide healthcare to folks if you don't know what their primary language is. So yes, I think we are absolutely working across sibling departments. As you know, we have much better data for Covered California and Medi-Cal race ethnicity data because Cal hears when folks apply, that data is being collected. So we have much better. I continue to be frustrated. We don't have better race, ethnicity, language data for commercial coverage and for Medicare Advantage. So Medicare Advantage is a little harder, but certainly for commercial coverage, we know partly how good or not good the data, how not complete the data is from our HPD data, where we don't have what I view to be an acceptable rate of race ethnicity data. So it's something that we're pushing the commercial payers on the HPD side, and absolutely something we're working with across sibling departments to push plans to do a better job. Also, I will say HCI also has a hospital equity measures committee, and we have done some we have done some sort of sharing of best practices about how to ask for the data. Certainly my experience, you've been on the front line, I've been on the front line. My experience is if you ask people in the right way, explain that it's voluntary, what it's being used for, most people will answer the question and give the data. So it definitely continues to be a work in progress.
I think the only thing I'd add is just to emphasize, for example, that some of the sibling state departments do have contract requirements to increase the reporting of member race, ethnicity, and other demographic factors that helps contribute to collecting this data.
Okay, and I certainly very much appreciate Dr. Landsberg's answer. I think, obviously it's not just on the agencies, right? We need to create the culture in the provider community and among patients that these questions are asked, they're not threatening, and they actually benefit the individual patient, no matter what their race, ethnicity, language, sexual orientation is that actually everyone benefits from answering that question, right? And so hopefully we can create that kind of expectation when someone comes to the front desk or, enrolls health plans, so we get that data. Thank you.
Elizabeth.
Just very quickly, I wanted to compliment the work. I've been in measurement world for decades, and there is no perfect measure set, but this is a really great sort of well-rounded approach, and the alignment is likely the most important. If we can just reduce the administrative burden and, just come to consensus on at least a few key indicators, I think it's just really important work. So thank you.
Thank you. Rick.
Thank you for the work. I look forward to the fall report on the patient safety measures and appreciate the focus, as Elizabeth mentioned, on alignment. And I know the statute requires alignment with other state agencies. It'd be useful also, I think, to look at the CDC, which, as you know, requires many of these HAI measures, and it wouldn't be an additional burden to collect measures that are already being collected by the CDC and include them in the measure set, even if they're not being included by other state agencies.
Thank you. We've done a bit of looking into the CDC, and especially in terms of the relationship between the CDC and CDPH and how they look at hospital safety measures. So that'll be part of our work moving forward as well, leading up to the fall.
Great. Thank you very much and appreciate that update for the board. We will now turn to public comment.
If you'd like to make public comment, please step to the podium. If you're online, please raise your hand looking to the podium.
Beth Bell for Health Access California. 3 points. First of all, we wholeheartedly agree with Dr. Pan about the need to collect better race, ethnicity, language, disability, sexual orientation, and gender identity. If he were still in the legislature, I would suggest my friends at CPEN approach him about carrying a bill to assure that commercial coverage collected this. But that is part of the current gaps in the law that at some point should be rectified and would be something that I would think, given this administration, there would be an openness to having conversation about. Certainly with respect to disability status, you would think health plans would know that today and providers as well. So it should be available information. Second, we look forward to having the discussion about patient safety measures. I can't think of anything that exemplifies the AAA more than reducing hospital-acquired infections and other patient safety measures like preventing falls. That is exactly the sort of thing where you have lower costs and better outcomes, and we hope improved equity. So that seems to me very symbolic, aligned, congruent with the goals that we have here at OCA. Thirdly, I will note that in some of the public comment, there was discussion about access measures. And I went back and reread the law with respect to that. And the law certainly does talk about access, but those of us who crafted the law understood very well that the Department of Managed Healthcare and DHCS have ample access measures and collect data on that. And rather than assigning yet another task to OCA, instead relied on the existing law. Thank you.
Thank you. Looking virtually, seeing no hands raised, noting we have about 64 virtual attendees looking to the podium. No one at the podium, no hands raised. That concludes public comment.
Thank you very much. And again, thank you for the work on that item. We are going to move to our final item, which is a general public comment.
We will now take general public comment. If you'd like to make a comment on any item on the agenda or anything not on the agenda, you can do so now. Please step to the podium or raise your hand if you are attending virtually. All right, noting for the record, we have about 64 virtual attendees and no hands raised and no one at the podium at this time. That concludes general public comment.
I want to thank again the public for engaging with the board throughout this conversation very actively, again, both in person and virtually. And again, just appreciate the continued thought partnership and consideration on this critical work that we have the privilege to do. We will see you next month, May 27th, same place, same time.